All right. So hi guys, good morning. This is if you are in Philippines, good morning. And if you are in, of course, United States of America, we are global today. So welcome for the Geriatric Rehab Summit. This is our fifth annual event, Geriatric Rehab Summit 2024. So for our housekeeping, we will be having our chat room. On the other side, we have the box. If you have any questions, I'm sure we have a part there. We can even ask on the chat room, and you have an option to unmute yourself if you have question or raise your hands later. And also, we have a webinar chat here. Definitely, we have an admin that can check if you have any question for the specific um, speakers. We will have speakers today, and I will introduce them for you. And at the end of their presentation, you can ask some questions, okay? So definitely we have hands out, and then the recording will be given for you as well at the end of this 2 days webinar. All right. So it's me, Dr. Jenny Yusuf. I'm a doctor of physical therapist and physical therapist based here in Delaware. This is our 5th year, and part of the proceeds goes to Future Foundation, a nonprofit organization. Thank you for your support. I'll introduce more myself later, but definitely we have this as our highlights here, okay? So this will be our event. So let me see. Okay. All right, this is our event for today, and this will be our speakers. So for our day one, our speakers will be Dr. Rick Beato, and the rest of our great speakers here will all be presenting for today from 4:30 onwards until 10:30 US time, Eastern time. All right. And this will be our schedule. So we're beginning, I'm doing the opening. And of course, our keynote speaker for tonight or this evening will be Dr. Morris Beato, our opening keynote speaker. And around 5 o'clock, followed by Dr. David Newman. And 6 o'clock will be Mark, our CEO of Ludofit, and 7 o'clock will be Dr. Erica DeMarch. We will have a 25 minutes break around 8 o'clock, and we will have again another two speakers led by Dr. George Rodriguera at 8:25, and our last speaker for tonight will be Dr. Juliet. All right. So let's see. And for tomorrow, we will have we will begin our day 2 at 8 o'clock. So we will open it at 8 o'clock, and we have Dr. Vrunda Kapadia. She will going to discuss more about geriatric specialist exams or different exam tips. From 8:05, we have Dr. Laura Gusay, and they will have 1 hour each, 45 minutes to some, and we will have lunch break at 12:20 to 1:10. All right. So again, this is Dr. Jenny Yusuf. So I'm a doctor physical therapist based in Delaware. I'm working right now in acute rehab, but almost like 21 years of physical therapy. I'm home health for almost like 12 years, and a board certified specialist in geriatric physical therapist. I'm also a certified lymphedema therapist and certified exercise expert in aging adults. Majority of you know me from Balance and Fall Support Group. I'm the president of Fishigen PT and Wellness. So thank you so much for joining. And I'm the current treasurer of the nonprofit organization, Future Foundation Global. It is a nonprofit organization that we help and do some scholar 1 year. We just fund and have some scholar for doctor of physical therapy, and we have 2 scholars already. So luckily we'll have more. All right. For our first speaker for this afternoon, we have Dr. Morris Beato, our keynote speaker. He will going to discuss about the clinical practice guideline in geriatric clinical practice. So Dr. Morris will be going to discuss it just like an opening, especially we are in geriatric rehab. But who is Dr. Morris? So Dr. Morris is the director of the University of Central Florida and Orlando Health Neurologic Residency Program. He is a clinical associate professor in the DPT program of UCF's School of Kinesiology and Rehab Sciences in Orlando, Florida. He is a board-certified specialist in both geriatric and neurophysical therapy. So that's amazing, Dr. Viado. And he is also the past chair of the Neurologic Specialty Council and Geriatric Specialty Council of the American Board of PT Specialties. He is currently serves as a board member of the ABPTS, and Dr. Biaro is the recipient of Outstanding Educator Awards from the Academy of Neurologic Physical Therapy and the Florida Physical Therapy Association. He has received the Distinguished Mentor in Residency and Fellowship Education Award from the Academy of PT Education. He has been published in peer-reviewed publication, including the Journal of Geriatric Physical Therapy, Journal of Stroke and Cerebrovascular Diseases, and the Journal of Acute Care Physical Therapy. Clinically, he treats patients in subacute, home health, even outpatient care, especially, I think, during summer, right, Dr. Morris? And of course, without further ado, recently, it's not listed here. He just awarded as the recipient of the Lucy Blair Award this July. So congratulations, Dr. Morris. We are so proud of you. I'm giving the floor now to you.
Oh, thank you, Jenny. Thank you, everyone, for inviting me. Yes, just think of me as that was such a long introduction. Thank you. But like you can just think of me as Rick, the physical therapist. In fact, I was just doing Oasis yesterday. I was trying to finish up my Oasis. I was like, oh no, they're going to do the notes and they're going to say, here are the diagnosis, the ICD then fix it. Anyway, so yes, so I do treat patients a lot, especially in the summer. I treat half of the time I am in the residency program teaching at the university, but I would say majority of the days I'm treating in the skilled nursing, I'm treating in home health, I'm treating in outpatient. So yes, I have to follow certain productivity standards and everything else that we have to deal with, right? Whatever equipment we have. But anyway, thanks for inviting me. Let me just share my screen. I am going to talk about clinical practice guidelines. So thank you so much for inviting me, and thank you for listening on my push for the clinical practice guidelines. Since the American Physical Therapy Association, the Academy of Orthopedic Physical Therapy, which is also known as the ortho section, right? So the neuro section is the Academy of Neurologic Physical Therapy, cardiovascular, and especially the geriatric section or the APTA geriatrics. There has been a push for the role of the clinical practice guideline. So hopefully, there will be a final push as we go into clinical practice because we think about evidence-based practice. When we get a patient, we think about, you can see here, we think about like, what are the things that we can do for our patient, right? There's so many things, like let's say low back pain, but then you pull an article, there's so many articles that we're looking at. There's thousands of articles that are available. So how do we know which are the good evidence, right? And even if we know which ones to look for, we do not have the time with all the productivity standards that clinicians, that we face every day. We don't have the time to look at every single document and then critically appraise the literature. So what does the clinical practice guideline provide? Think of it as, the students are always asking me, it's like, isn't there a recipe that we can just use to treat the different conditions? Used to be the answer is no, but now the answer is yes, right? There is a recipe book. The clinical practice guidelines make our lives easier as physical therapists. So think of them as recipe books, right? Think of all the research, the high quality research, a panel of experts, which looks into a certain specialty of physical therapy, let's say neurology, right? Like let's say Parkinson's disease. So all the Parkinson's disease experts appointed by the neurologic section and the American Physical Therapy Association, as well as the geriatric section, they're going to look at all the evidence, right? And based off the evidence, they're going to pull the recommendations. Here is, they're the ones who are synthesizing. So we do not have to synthesize the evidence because we can look at the evidence, every single one, but what the clinical practice guideline does is it provides us the opportunity to look at the decisions, at those evidence where the experts have already looked at it, and then they summarize it for us and they give their recommendation. So you can see that there will be different types of recommendation in a clinical practice guideline. So let's just define the clinical practice guidelines. So CPGs, right, based on the National Institutes of Health, it is a systematically developed statements, right? So clinical practice guideline, when we look at them, it's not like validity studies. It's not like the different types of interventional studies. When you look at it, it's all mostly statements, right? They have statements, but then they provide you the evidence. But the statement tells us what to do, right, with a certain condition that we meet in the clinic. The goal of it is to assist practitioners, healthcare practitioners, and the patients, right, to make the appropriate decisions regarding their healthcare and the condition that they have. So when we look at the CPG, right, it contains the guideline statements. So when we're looking at the CPG, I'm going to pull an example later. Those guideline statements are the statements based off the research and the recommendation of the experts, the panel of experts that have looked at those high quality evidence. They look at the published literature and they have underwent a rigorous systematic review. So all these articles, right? The high quality articles, they select only the high quality articles, the high quality studies, and then they synthesize it to make it digestible for us. Like think of it as a recipe book. Since clinical practice guideline is a form of evidence, let's take a look at the pyramid of evidence, all right? Let's just review. So clinical practice guideline is now the one on the top of the pyramid. Before, we used to think of systematic reviews and meta-analysis as the highest level of evidence, right? We know that the case series are the lower forms of evidence. There's just one case study, or then multiple case studies will be a case series. And then you have the randomized control trials where there's two groups that are compared, right? The intervention and then the control group, the one that doesn't receive the treatment. And then based on, right, summarizing those studies, we come up with a systematic review or meta-analysis. Well, clinical practice guideline pushes this even further by recruiting the panel of experts, right? The top experts in the field of physical therapy, not just that specialty area, but the subspecialty within that specialty area, in order to create those statements that physical therapists can use as a recipe book to make those clinical decisions regarding the diagnosis. So think of the middle one, right? The middle portion of the pyramid, the RCTs, or the randomized controlled trials, the cohort studies, case control, and case series. Those are data, right? These are the data that are being provided. Like we know that these are coming from those patients, what happened to them after the intervention. And then we look at the synthesized data, the top of the pyramid, right? The systematic review, meta-analysis, and now the introduction of the clinical practice guideline. These are filtered data, right? It's already summarized, right? They already told us the recommendations. These are the strong recommendations for each of this condition. So how can we visualize a clinical practice guideline? Well, if you take a look, right? Take a look at different randomized controlled trials. So there's different randomized controlled trials that are being looked at. And then the panel of experts will have a rigorous review and synthesis of that randomized controlled trials. And then they're going to pick out, right? They're going to rate the evidence and they're going to make and summarize it and give us to us as an action statement. And then looking at the lowest level of evidence, it's actually not even evidence, is an expert opinion. Sometimes we're going to think, like, well, there's no data to make a conclusion, right? So like, why is expert opinion even valuable? Well, an opinion is not valuable, but the opinion of an expert can become valuable because there are times wherein there are certain diagnoses, like let's think about some cardiopulmonary diagnosis or neurodiagnosis that are a little bit rare, right? They're not common, and so they're not being studied. And there's only like, the only thing we have is an expert opinion. So at that point, the expert opinion, the experience of the expert becomes valuable because there is no cohort studies, there's nothing above the pyramid that we can look at in the published literature. So the expert opinion becomes important at that point. So again, these are the clinical practice guidelines are made up of those statements and recommendations. And what is a sample of that recommendation? Let's take a look. So looking at the recommendation, a sample action statement, this is taken from the Parkinson's Clinical Practice Guideline from Osborne et al., right? She actually lives here in Florida, Jacqueline Osborne. and from the Academy of Neurologic Physical Therapy and Academy of Geriatric Physical Therapy. So when we look at the clinical practice guideline, the first thing you're going to see are recommendations, because those are the summary, the synthesis of that literature. So what does the clinical practice guideline for Parkinson's disease tell us about aerobic exercise? Here's a great example. Physical therapists should implement moderate to high intensity aerobic exercise, right, to improve oxygen consumption, motor disease severity, and functional outcomes in individuals with Parkinson's disease. Let me just erase all the drawings so that way you can see it clearly. So, right, we saw that a sample of these clinical practice guideline is the action statement on aerobic exercise. So what kind of aerobic exercise should we be using based on the evidence? It tells us here it's moderate to high intensity. So you can see the recommendations, those action statements, they'll tell us specifically what we need to do in order to improve our patients in physical therapy. And it will tell you there's the evidence quality, which is high. That means in the literature, the type of studies that they've studied, there's multiple high quality studies that proves that aerobic exercise actually improves oxygen consumption, motor disease severity, and functional outcomes in people with Parkinson's disease. And then on top of the evidence quality, you're also going to see another one, the strength of the recommendation. So sometimes they're very similar, right? The quality of evidence tell us about the research, the quality of the research. But the strength of the recommendation will tell us how applicable this is in our clinical practice. This is what I like about the panel of experts. They have clinicians from different clinical settings, right? They could see that, like, let's say, robotic exercises, right, will be amazing. So there's going to be high quality of evidence. There's multiple research saying robotic exercise are excellent ways to improve neurologic patients. But then the panel of experts will say, well, we don't have robots in the clinic, right? A normal outpatient clinic doesn't have a robot. We don't have that in the nursing home. And so the recommendation, the strength of recommendation will be a little bit weaker. It could be just medium, or it could be weak, because to buy those robots, they're very expensive to buy those robotic equipments. And so the strength of recommendation will be a little bit lower. So there is the evidence quality. What does the research tell us? How effective it is, or how not effective an intervention is. But there is also, right, the strength of the recommendation. The strength of the recommendation will tell us whether how applicable this is in our clinic, and can we carry out, right, these interventions easily in our clinic. So you can see those recommendations. Those are the action statements that you can see for a clinical practice guideline. And if you want to look further, it will tell you there are 9 high quality studies and 7 moderate quality. That's how they came up with this rating, based off those studies that they have looked at, the panel of experts. So it's not just random individuals that are like, oh, let's pick a physical therapist to look at this clinical practice guideline, people who don't have any idea about the diagnosis. These are actually the experts in their field who are synthesizing the evidence for us. Let's look at another one, right? An action statement. So when you see the low back pain clinical practice guideline from the Academy of Orthopedic Physical Therapy, you can see the summary of recommendations, very similar to neuro, right? It tells you there's the recommendation. Those are your action statement. So you can see exercise for acute low back pain, but you can see the quality of evidence is a letter C, right? It's a little bit lower than A and B, but that's the evidence that's available for acute low back pain. It says we should use trunk muscle activation for acute low back pain. In contrast, when you look at the chronic, right? So here's acute, but here you're looking at chronic low back pain. The evidence that is available is a lot of evidence. So you can see the strength of recommendation and the quality of evidence is A, versus for acute low back pain, it's only a C. And if you look, the intervention's a little bit different, right? We saw here trunk muscle activation for acute, but then we're going to look at the chronic one. You can see that there is specific trunk muscle activation, multimodal exercise, aerobic exercise is effective for chronic low back pain, aquatic, general exercise for patients with chronic low back pain. So, right, instead of us looking at the evidence individually, we can just see the strength of the recommendation. It will tell you specifically what kind of exercise that we should be providing for these patients with different types of conditions. So think of it, really, it is a recipe book when we're looking at clinical practice guideline. So what is the objective? What is the objective of the American Physical Therapy Association and its sections and academies? The objective is to support evidence-based practice. So we're not just practicing whatever we learn from school, but we're actually practicing what the latest evidence, what is the latest evidence, what is the highest level of evidence that is out there, right? That's what the clinical practice guidelines are for, to assist us in clinical decision making. Again, they are conducted by a team of experts, and they are reviewed like a systematic review and meta-analysis and published by the APTA, the American Physical Therapy Association, its sections and academies, the big ones, the orthopedic, geriatric, neurology, cardiopulmonary, but even the sections, the moderate size sections have them too. But it's not just the APTA that have them, right? Sometimes there is clinical practice guideline coming from other healthcare organizations, such as the VA, right? So the Veterans Affairs have multiple clinical practice guideline in different conditions. Let's say for individuals with spinal cord injury, they have one. But then the Academy of uh, ENT, right? The otolaryngology, they have the BPPV, the benign paroxysmal positional vertigo clinical practice guideline. So we do not need to create one for the PTs because there's already one existing for EENTs and other healthcare professionals like PT. So other healthcare organizations also have the clinical practice guidelines and other societies. It's not just exclusive to us as physical therapists. What we also need to remember, what CPGs are not, right? So we think about it as a cookbook, right? So instead of us doing the traditional, let's say low back pain, here's combo number one, right? TENS unit, hot packs, and massage. And here's combo number two. CPGs are recipes. They're better recipes. They tell us about which evidence, right? How strong the evidence is for certain interventions. But what CPGs are not, they are not fixed protocols. Just because the CPG tells us that, okay, here's the aerobic exercise, we must do either treadmill or let's say bicycle for patients with Parkinson, doesn't mean we're going to be married to that. If our clinic doesn't have a treadmill or doesn't have a bicycle, as long as we're getting the recommendation of moderate intensity, and it could be overground training, right? It doesn't have to be fixed protocol. The CPG can be used as a guide, even though if we do not have those equipment. So they are not fixed protocols that must be followed, right? You can tweak it. In the end, they are recipe books, but you are the chef, right? You get to decide whether it needs a little bit more vinegar. It needs more tomato sauce, right? So think of those conditions. We can tweak the guidelines depending on how our patients clinically manifest. Another one, you have to remember, CPGs are general recommended course of intervention. The key word is general. They are not a substitute for the advice of a physician. Just because the BPPV clinical practice guideline says this is what we need to do for a posterior canal, doesn't mean, right? And then we're thinking, well, maybe there's another canal. It looks like there's two canals involved. So it is not a substitute for the advice of a physician or a healthcare professional. And the most important one, it does not take the place of clinician's judgment. So even though the strength of the evidence is very strong, let's take, for example, the stroke locomotion clinical practice guideline, right, for individuals with chronic stroke. It tells us that we should do high intensity walking, right? So think of your patient. Okay, here's a stroke patient. The recommendation, the strength of the recommendation is A. The strength of the evidence is A. We should be walking our patients with high intensity. That means we need to reach at least around 60 to 75% of the heart rate maximum. But then you look at the patient, well, the patient has a lot of history of heart attack and stroke, and they have a contracture on the leg, right? And so when you put them in the treadmill, they are going to like struggle in order for you to reach the 85% maximum heart rate. So you must use your clinical judgment that like, okay, my patient is at risk for heart attack and my patient is has a contracture, is not able to achieve this. So you're going to tweak the clinical practice guideline, maybe lower the target heart rate, right? So it's not substituting for your clinician's judgment. In the end, you are the chef, right? You are the ones who is going to tweak and give the intervention. So just use the CPGs as a guide, but they are not going to be a substitute for our clinical judgment. The history of the CPG, right? The orthopedic section, the Academy of Orthopedic Physical Therapy, started a project of CPG in 2006. We think about the ICF model, right? For those of you who have heard the ICF, the International Classification of Functioning and Disability, this is from the World Health Organization. It tells us that we should be using this type of model versus the NAGI model that we were used to, because this is, instead of the disablement model, of the NAGI, this is an enablement model, right? It looks at what the patient can do versus what the patient cannot do. And the ICF, the goal of the ICF, right, by the World Health Organization is for us, the different healthcare professionals, it doesn't matter where you are around the world, we must be talking about the same thing if we use the language of the ICF. Let's say a speech therapist in Japan, when she talks about expressive aphasia, the speech therapist, the physical therapist in South America, the occupational therapist in Canada, right, or the physiotherapist in Australia should know what an expressive aphasia is. No one should be using Broca's aphasia anymore because in the ICF, we're using, right, participation measures, the language of the World Health Organization. That is the purpose of the ICF. But anyway, so since the ICF language has been used, the orthopedic section, right, we look at the elements of patient-client care management, which is present in the Guide to Physical Therapy Practice. You can see that, right? So they based off the CPGs based on the elements of patient care management using the ICF model that we have. So what is the process for the clinic? Right? Oh, sorry. Am I muted? Oh, there you go. I'm unmuted again. So sorry. There you go. So what is the process for a clinical practice guideline? So for the orthopedic section, you can see there's a planning, right? You can look at the authors. Those are the panel of experts. And then they do the literature question. They do a systematic review, a draft. And then there's a feedback from other PTs, right? From the APTA members, the consumers, the patients, and then the final draft. And then it is published. And then there is knowledge translation into the clinic. This doesn't happen in 1 week. This happens in years, right? So the process takes years in order for us to get the final product of the clinical practice guideline. And every 5 years, each of the clinical practice guideline is updated because new literature will come out. So every 5 years to 6 years, 5 to 6 years, usually a new clinical practice guideline is revised. So what are the following conditions that we have a CPG that is related to geriatrics, right? So low back pain, hip fracture, carpal tunnel, neck pain, patellofemoral pain, hip pain that is osteoarthritic, hip pain that is a non-arthritic hip joint, and then elbow pain are available in the Academy of Orthopedic Physical Therapy section. So you can go there and use that. And then for neuro, you have the vestibular hypofunction, locomotion function for chronic stroke, spinal cord, and brain injury. The use of AFOs, right? Some of us, like, when do I use this type of AFO or a functional electrical stimulation for stroke? There is a clinical practice guideline already existing for that. Concussion, Parkinson's disease, and what are the outcome measures we should be using for all neurologic patients. For cardiopulmonary, there is when do we use, right? When the patient needs an oxygen and we're doing a PT intervention, what is the right way of titrating the oxygen and when should we use it? There is already clinical practice guideline existing for that. The role of the patient of management, right? Let's say there's a patient in acute care or in subacute, there is at risk or actually have a DBT. There is a clinical practice guideline for that. For patients with heart failure, when do we give the correct intensity of exercise? There is a clinical practice guideline for that. For patients with hip fracture, we talked about this, right? In cooperation with orthopedic section, geriatrics has it, as well as suspected or confirmed patients with osteoporosis. What do we do with these patients and what intervention should we be giving? So those are available. So again, graded recommendations. You can see the strength of the evidence. There is a graded recommendation, and then the opinion of the expert. What is their recommendation? It's also graded, right? Because these are there's a stringent methodology. The process is formal. It's the same process used in all the CPGs, in all the academies of the American Physical Therapy Association. They follow the same standardized review of the literature. They must meet the standard required bridge to bridge the gap between evidence and the recommendation, right? Like, here's what they found in the studies. So what are the recommendations? And then we have to do the knowledge translation. But now think about each clinical practice guideline. We talk about this, right? What does the quality of evidence tell us and how applicable it is in the clinic based on the experts' synthesis of the literature. And that's how we come up with the clinical practice guideline. So after the CPG is published, what do? We just read it. How can we translate that into the clinic? That's what we call knowledge translation. So you can see a lot of the big academies of the American Physical Therapy Association pushes for knowledge translation. So the research literature, right, that we can see, that we read, can be translated into our clinical practice. How can we do this feasibly in our clinic with with the limitations of equipment, the limitations of productivity? That's why there's knowledge translation task force from each of the academies. Again, each of the action statement you can see, right? The action statements are there. You can see the level of evidence is being graded. And when you look at the CPG, they are free, right? It tells you A is a strong evidence. There's level 1, level 2 studies. B is a moderate, single high quality, and so on and so forth. So you can see here for this is for hip fracture. This one is A, strength of the evidence. High intensity resistive strength is okay for patients with hip fracture. So A is a strong evidence based on the recommendation of the expert. And then the evidence is level 1 and level 2. When then you look at the core outcome measures for every neurologic patient, it tells us that these 6 measures should be used, whether you're in acute, skilled nursing, outpatient, home health, or inpatient rehab, that these are the 6 measures every neurologic patient should use, right? So we have those clinical practice guidelines. And we talk about implementation tools. So each of the academy created a tool. So there is a CPG for the core outcome measures, right? The 6 outcome measures we should be using in neurologic patients. When you look at the website, there are actually tools that we use in the clinic. So this is an example of the report card. So all our students take this into the clinic during clinical internship. You can see, right, the 6 core outcome measures in the CPG. They made it easy for us as clinicians. Like, here's the form. All we need to do is administer the test and write down the scores of the patient on what date, right? So maybe this is the eval and this is the next session next week or the following sessions, and then the discharge. And then it tells you, right, whether the patient is a fall risk or not a fall risk. So the tools are out there. They are available. We must use them, right? For example, well, it says aerobic training is effective for Parkinson's. So should I just put my patient in the new step and then leave them? No, there's actually an exact recipe that they recommend. That means we should be treating them to improve aerobic capacity 3 times a week, 60 to 75% of the maximum heart rate. So we're not guessing because the literature already says 60 to 75%. And how long should I put that patient? 30 minutes. You can use either stationary bike or treadmill, right? So it is right there. If you look at that website and the CPG, the tools are out there. Please use them, right? Well, how am I going to measure aerobic training? Well, it even tells you, use the 6-minute walk test. What about for quality of life? Use the Parkinson's disease questionnaire aid. So those tools are available. They are free. All you need to do is look and click for them. For the locomotion clinical practice guideline, it guides us. What is a green light, yellow light, red light? Green light, right? In order for the patient to improve the walking of a chronic stroke, chronic SCI, or chronic brain injury, especially a lot of our older adults have TBI because they fall, it says moderate to high intensity aerobic walking, or walking with virtual reality is a green light. What is the red light? Which ones are we should not be doing? To improve walking, we shouldn't be doing balance exercises. We shouldn't be using body weight support. We shouldn't be using robotic assisted exercise. So, the literature is already simplified. It tells us green light, which ones to do, yellow light, which we may do, and the red light, which ones we shouldn't be doing, right? So I like this. So look at the tools. It's out there. It even gives us the heart rate, right? The target heart rate. So all in the facilities in Orlando, especially the 2 major hospital systems in their outpatients, especially in neuro, all the therapists are carrying this in their ID. If you flip their ID, they even have this. These tools are available. The neuro section, right? The ortho section, the cardiovascular and pulmonary section. They have their tools. Use them well. So, our hospitals and our clinics are using them, right? All the clinicians are carrying this. So they're not guessing and computing. They're just going to implement it when they have the patient back for, excuse me, therapy. So those heart rate, right? These tools are being used in the clinic. They are not just there for decorations. The algorithms are the easiest, right? Look at the algorithms. This is for vestibular hypofunction. You have a dizzy patient come to you, right? Are the patient dizzy? Do the patient have visual blurring, or the patient has an imbalance? Let me just take a drink. I'm talking too much. There you go. Sorry. So, so if the patient is complaining of dizziness, right? Yes, these are the tools that you're going to use. If they're complaining about visual blurring, oscillopsia, this is the tool that you're going to use. The algorithm specifically already tells us which ones to use. So not just the outcome measures, but it also tells you, right, which ones are we going to use for treatment. Like here, dizziness, you do habituation. Visual blurring, gaze stability. Hold on, excuse me. There's something in my throat. But anyway, so imbalance and falls, here are the exercise. There's the frequency that we should be using. And then for like heart failure, you can see green zone, right? The patient doesn't have short of breath. Continue the activity. Yellow zone, right? Patient is gaining weight in 24 hours. Then maybe this is the step that we should be doing. Red zone, shortness of breath at rest, you shouldn't be doing exercise. And you can see, right? You just need to follow the clinical decision tree or the steps for this. So in summary, right, use the CPGs to guide our clinical decision-making. They are not substitute for our clinical decision-making. They are there for guides. Use the algorithms, right? There's clinical decision trees. If we need to use certain things, right? Okay, what do I do? Should I do this? Should I push through with the treatment? It tells us exactly what to do. Use those clinical decision trees. They are available. These clinical practice guidelines are free. They are available online. All you need to do is go to the Academy's website. You do not need to be a member, but those are available publicly, right? They have them on their website. Look at the strength of the evidence, right? If it's an A, go for it. If it's a B, you can still go for it, right? But if it's like a D, then maybe you should think twice of using the evidence. Then look at the recommendation. Can we do this in our clinic? The strength of recommendation is also there. And then the most important one is the knowledge translation tools. Those tools are free. You just need to download them. We can use them. And so, you know, that those are the things that are available for us as physical therapists in order for us to use the interventions and the tools that has been validated, that are reliable, and is most effective for our patient. So that's it. I hope you all start using the tools that are available online. Thank you. And those are the references.
Wow, that's just very only 30 minutes for that compressed knowledge. So guys, are you familiar with some of the things that Dr. Morris discussed? That's really good, right? We are always hearing those with research, Dr. Morris. Go ahead, Kurt. Do you have a question? Do you have a question, Kurt, or you just raise your hands that you're familiar? Thank you so much. We appreciate you. So we have a chat and I believe we have a QA part there. Yeah, here on the bottom. So do you have any questions so far, guys? Dr. Morris, can you put on the chat as well? If ever you have how we can connect with you. I know you're a professor, you have lots of students, but anything that we can chat with you, definitely ask more questions. And also, Net, I think you have a question. Go ahead. I think you have an option to unmute.
Yes, I think I have an option to talk. So, uh, I'm an outpatient physical therapy, so I'm not dealing much with these clinical guidelines for elderly, but I also work like part-time in a geriatric setting in a nursing home. But I want to ask, like this is always a question for us whenever we have like an in-service in the outpatient department. Like how often are these clinical guidelines being updated? Because like, for example, in your low back pain, GP clinical guidelines, you said about the evidence A for low back pain, but when I look onto the interventions that were being told there is not yet partial mobilization or dry needling techniques that were included. So part of me is just asking like how often do they update our clinical guidelines?
Oh, no,
Thank you.
Thank you, Netherine. That is a great question because you know, I work in the nursing home and I work in outpatient and home health as well. But the target really for each clinical practice guideline is every 5 years. So you know, if you go to the website of the Academy of Orthopedic Physical Therapy, it will tell you specifically the years each of the clinical practice guideline was created, and it tells you which ones have been updated 5 years ago. But sometimes there is a delay, right, with the clinical practice guideline, because I'm with the Balance and Falls clinical practice guideline. So I'm one of the reviewers for the literature. And, you know, there's a target date, but then you're going to see, oh, there's more literature coming in, right? Next year, there's more literature coming in. So you're trying to include all of them, but so it gets delayed and delayed. But the target is really every 5 years, and you can see the dates on the Academy of Orthopedic Physical Therapy, for like, let's say for low back pain, you can see specifically the original, and then you can see the revised. The Academy of Neurologic Physical Therapy has the same. They have the dates, and it will tell
Yeah.
you.
Thank
exactly.
you so much. That's very informative. I love it. Thank you.
I love it. Our artist. All right. Thank you so much, Dr. Net. And she will be one of our speaker tomorrow for pelvic health. And thank you so much, Dr. Morris. We really, that's really informative. It's a great for us to learn more about that. And if you have other questions, definitely connect with Dr. Morris. It's on the chat box, right? So this is one of our keynote speakers. Of course, we would like to thank him for this wonderful knowledge that we have. As a token of appreciation, we have a certificate of appreciation for Dr. Morris. Thank you so much for sharing his knowledge and expertise as the keynote speaker of Geriatric Rehab Summit 2024, August 16 and 17. Woo! And this is live in Delaware because that's where I am.
Thank you.
All right, but this is global. Thank you guys for all the hearts and the clap. Woo! That's
Thank you,
another.
everyone.
You're welcome, Dr. Mars. This is another certificate of all your awards and achievements. Treasure it, Doc. Okay. Thank you. All right, guys. For our next speaker, we have Dr. David Newman. He's an orthopedic surgeon, and also he's going to discuss how to age gracefully using technology and resources. All of us dreams to be age gracefully, right? But Dr. David Newman will going to discuss that to us. And to learn more about Dr. David, he is a serial doctorpreneur, an author, an inventor, and owner of New York Sports Care, located in New York City. He's board certified orthopedic surgeon, specialty in sports medicine and arthroscopic surgery. Dr. Newman's professional membership includes American Medical Association in state of New York and the American Academy of Orthopedic Surgeons in a leadership role. And Dr. David performs more than 5,000 surgeries, where he also serves in sports medicine surgeon and also in philosophy. And his goal is to improve excellent outcome as he focuses on restoring patients' functional ability at work, play, or sports. So currently, Dr. David consults in orthopedics, and his passion of promoting exercise therapy, non-invasively way, and also non-pharmacologic interventions, prevention, and fitness. So this is manifested as inventor of a lower back elongation device, a medical director of Ultra Pain Products, and co-founder of PopDoc. PopDoc is a groundbreaking digital therapeutic healthcare technology company. So some of the home exercise programs, we can also have that EMR in your clinic. So we have this therapy programs to help population feel less pain and stay as functional as possible through fascia training and reintegration. So they strongly believes that healthier joints make happier people. So welcome, Dr. David Newman. Welcome.
So happy to be here, Jenny. Thanks for that mouthful you just shared with everybody.
You're welcome.
I'm very
Well
appreciative, and thanks for allowing me to come and spend some time with you guys this evening, or this evening where I am.
Where are you? New York?
I'm in New York City, yes.
All right. Go ahead, Dr. David.
So, I jumped on a little bit a little while ago, and I was listening to Morris's talk. It seems like it was pretty incredible. As time goes on, the data that we have, that people have, that the world has, it just keeps on growing. And I think some of these clinical practice guidelines help make work more efficient for the physical therapist. And it also allows you as physical therapists, or just people caring for others, to meet them where they are and then hopefully elevate their function and elevate their capacity in the world. So I'm going to try and share my screen. I'm going to go through a quick talk that I put together a little while ago, but I've updated it recently. And ultimately, when you have patients that are not scared of technology and want to continue to supplement physical therapy with exercises at home exercises of any way, shape, or form, then this is a product to help achieve these types of, I guess, new technologies, ultimately empowering the patient to get better, stay better, love the work that you do with them, love you for the tools and resources you give them so they can hopefully age gracefully. So I have some objectives today in the talk, and what I'm going to do is go through this presentation. I'm happy to answer some questions afterwards. So tools and resources to assist people as they age gracefully. So physical therapy is an awesome tool, but it doesn't usually go on forever. So if you can give them something to take with them, some knowledge, as Morris was talking about, you bring the knowledge to them, and you also give them action items to fulfill their goals. So the objectives. So when I talked to Jenny, she's like, "Oh, let's talk a little bit about some of these orthopedic conditions too." So I'm gonna briefly touch on all of them as well. So defining and discussing osteoporosis, compression fractures, osteoarthritis, the important role of professionals to optimize rehabilitation, successful methods to incorporate technology to help aging people achieve their goal of living an active and pain-free life, and the benefits of embracing a healthy lifestyle more than just physically as we age. And there's certainly a lot of new research out there about like what are the key components to aging gracefully. So what am I talking about with the musculoskeletal system? I think a lot of you guys are practitioners and so you know this already, but I just like to once again meet people where they are. Just I want to start as a foundational level. And so it's big system. As you know, it's complex. It's very integrated to the neurological system, which is why in the last year or three, we've been bringing on like the term fascia as the intersection between the neurological system and the musculoskeletal system. So in the musculoskeletal system, 206 bones, 360 joints, 126 of them are extremity joints. There's 33 individual vertebrae and 640 muscles. So you wonder why physical therapists are so busy. It's because there are so many joints and so many potential injuries. And as we unfortunately here in America, the population is not that healthy. There's a lot of sick people out there who have some musculoskeletal conditions, and it only becomes worse as you age. So what is the burden of musculoskeletal disorders in the USA? And it's about 10,000 people a day reach 65. So there's a lot of people out there that are potentially patients or potentially suffering with some pain. So life expectancy is around 76.3 years. It's declining since 2016. COVID didn't help too much, but it's still declining. Musculoskeletal disorders affecting about 75% of the people over 65. That's 3 out of 4. And even if you're younger, even in your teens and early 30s, it's still around 40% and even up to 50. So it affects about 127 million Americans, probably a little bit more now, but it's about that. And annual care is around $874 billion a year to care for people with musculoskeletal disorders. So it's a big burden on the healthcare system. What are some of the problems affecting elders? As we know, you might have an elder, you might be an elder, you might treat an elder. So musculoskeletal dysfunction, joint pain, loss of balance, faltering independence, chronic medical conditions, and a sedentary lifestyle. All of these problems lead to a diminished happiness and an increased risk for chronic pain. So what are some terms to understand? So Morris did talk a little bit about osteoporosis, osteopenia, and stuff like that. So what is osteoporosis? So that's a condition in which there is a significant decrease in the amount of bone or the mass of the bone and the thickness, the density of the bone tissue, causes bones to become weak and break or sustain injury more easily. They are at risk of injury when you're osteoporotic. It's essentially loss of calcium, essentially, is the main element in your bones. And then osteopenia is a condition in which there's lower than normal bone mass. So it's one less degree of severity compared to osteoporosis, in which there's a lower than normal bone mass, and the bone mineral density of the thickness or the amount of mineral contained in a certain amount of bone. So what happens when people are osteoporotic and osteopenic? Well, they have a simple trip and fall, or they land on their buttocks or something like that, they can sustain a fracture or a deep bruise to the bone and cause a higher likelihood of injury. So what's a compression fracture? Well, fracture in the medical term is a break, which is the lay term. Broken bone, fractured bone, same thing. Compression, as the term describes, you're compressing two things against each other. Usually it's a joint, which is the coming together of two or more bones to create motion. So when you have a compression fracture, they break the bone in a direct axial impact or chronic axial compression across a weight-bearing joint. So that could be your ankle, your knee, your hip, or anywhere around your back. So SPONC is a term that we use in orthopedics. It's a special name for chronic overuse, non-traumatic onset of pain in the knee due to this thing called spontaneous osteonecrosis of the knee. And this involves the cartilage surface or the bone just below that, which is called the subchondral bone. So someone who's overweight, who's got limited endurance or conditioning in their muscles, if they walk for too long, their muscles get tired, stop functioning. So the knee bones have to compress each time they walk, and it causes a bruise to the surface of the bone. So that can be very painful. It causes this thing called inflammation, which is stiffness, swelling, warmth, and pain. That can also lead to a loss of function, as you might know. So we can address this through physical therapy to alleviate the pain, regain range of motion, and ultimately strengthen the muscles and build the endurance of the muscles. A SPONC, or a spontaneous osteonecrosis of the knee, some orthopedic docs and certainly some physiatrists or some primary care docs will be like, oh, meniscus tear, chondral injury, MRI. But a good clinical examination might be like, okay, 8 to 12 weeks of limited impact and your pain should resolve to a baseline. So knowing these terms and what it might be can help the practitioner maybe save some money for the patient's healthcare or health plan, or just, give the patient some knowledge to say, all right, you'll be okay. Just give it this thing called time and alter your activities a little bit. So osteoarthritis, this is the term to describe a painful breakdown of a joint. So the word itis, or the suffix itis, I-T-I-S, usually means a painful condition. Bronchitis, osteoarthritis, gastritis, usually pain, itis, I-T-I-S. So most joints at 50 are degenerating at least a little bit because they are 50 years old. So all this smoothness and the nice, less friction, smooth, soft tissue structures in the knee allow you to, be happy, have minimal pain, good motion, and good function. But this thing called osteoarthrosis, meaning if you take an X-ray and you see diminished joint space or a few extra bones on the sides called osteophytes, but it doesn't depict pain, meaning you don't know from an X-ray if someone's in pain or not. So that's called osteoarthrosis. So when you have arthrosis or tendinosis, which is just your tendons don't look perfect on imaging. However, they may not be painful. So when they're non-painful, but there are changes on the MRI or the X-ray, called arthrosis. When somebody is then suffering with pain, meaning they have a perception of a feeling of pain, whether it's dull, achy, sharp, stabbing, burning, whatever it might be, pain, and everybody perceives that differently, then it's called osteoarthritis if the imaging does show some breakdown. So it's good to know the difference because a lot of people just use the word, oh, I got arthritis. I'm like, well, are you in pain? Like, no. I'm like, you don't have arthritis. Right now you have arthrosis because you are 55, 60, 65, maybe a little overweight, maybe a little out of shape, maybe you've had some injury in the past. So osteoarthrosis is the term used to describe a painless breakdown of a joint. So sarcopenia, which is certainly a great term that's kind of, I guess, coming more into the forefront over the last several years because people are trying to describe things so that patients can have better knowledge of what's going on within their body. And as you age, there is a progressive loss of skeletal muscle. It's just a normal part of aging. However, and when it becomes pathologic, when you see that your muscle tone in your arm or your legs just diminishes, and you're like, where'd all my muscles go? That's sarcopenia. So that's a condition from a progressive skeletal muscle mass loss, and you lose strength and you ultimately lose function. So people in this world are living a sedentary lifestyle, especially as we age with all the great stuff on TV, and people just rather be on the couch watching TV or sit at their desk if they're working and or drive instead of walk or bike or something like that. So sarcopenia is not great for sure, because once your muscles, as I said, once your muscles get tired, then your bones are carrying you around, or your joints, and you start to get that chondromalacia, the bruising of the bones. You might get a compression fracture of some sort. So sarcopenia, it's certainly something that is reversible, which is the beautiful thing. The data that's come out these days is like, even if you're 80 and you do the right exercises, you can grow skeletal muscle mass and hopefully be stronger, have therefore better balance and ultimately more function, so you can live and age gracefully. So joint pain, and once, as I said before a little bit, pain comes in many shapes and sizes, different colors. Everybody perceives it differently. There's no way to objectively measure it yet, because everybody perceives pain differently. And that's our two-way street of our nervous system. So if you bang your arm against the counter and you get a black and blue mark, your pain might be different than my pain. And or if you, the oldest example is you stick your finger on a hot stove and you pull it away really fast. You feel the pain, nerve goes up to your brain, says, hey, you don't want to do that. You pull your finger away, and so the nerve sends a signal to your muscles to pull that finger away from the stove. So the human cost of joint pain, whether it's acute or chronic, and acute means it happens with, from a traumatic event, or it just happens, at one point. When it becomes more than 3 months old or 12 weeks old and you still have that pain, you guys as people, but you're also practitioners, but you also might have family and or clients or patients that are also suffering with this thing called pain. You're like, why is this going on for 3 months? Once it hits like 3 months, it becomes chronic. So that means it's going to be there unless you really work hard to overcome it. But so what is the human cost of this pain? And as you can see, there's suffering and there's depression and drug dependence. I'm sure you guys have all heard of the opioid, epidemic and all the craziness that goes on with people who are stuck on opioids. That's horrible. Damaged relationships with friends and family. You can project, you have chronic pain, you might project this onto your friends and family by having a less tolerance of them or becoming more frustrated with little things. And then it's also prolonged and costly treatment. So once you have joint pain and you go to people like me, like an orthopedic surgeon, they want to inject you or do surgery on you. So that's costly. And they might want to get an MRI or get a CAT scan or do things that just cost money, a lot of money. And it doesn't always help because they are just treatments, they're not cures. So I love orthopedic surgery. I think it helps a ton of people. I've had a few of them in my life, and I'm grateful for my surgeon because they got me to overcome pain, get back into a livelihood of an activity level that I like, and it allows me to potentially age gracefully. So reduce productivity. When you're thinking about your joint pain, you're not really productive in your life, whether it's you're taking care of your children or you're trying to do work or you're trying to, just do things you like. Lost independence. So this is one of the key things I think as people age is their independence starts to wane. Whether it's pills that they're reliant on, whether they're reliant on a home care agency, whether they're reliant on a cane or a crutch or a walker or a wheelchair. Something just happened to my. You guys okay on this? Okay. So, and there also can be diminished morale. Somebody with chronic pain might not feel like they are all they can be, and they're not bringing their best selves into the world every day. So how do you overcome your pain? I came up with this acronym many years ago, and it's called before you're active, be preactive. Being preactive is overcoming your pain before you're back and active again. I believe in like the power of positivity, getting rest, elevating, using anti-inflammatory and pain medication like Tylenol. I'm definitely a non-narcotic kind of doc. Compression helps kind of diminish some of the swelling and inflammation that you have in and around muscles, bones, and joints. Topical products becoming more favorable these days because they don't really enter your system too much, but those can be like an Aspercreme or a Voltaren gel. It's an anti-inflammatory. There's also some nerve altering perception things like capsaicin cream or biofreeze. And there's a lot of topical products, and CBD is also getting more common, where it's like it gets into your system and calms some of the feeling of pain. I for ice. Ice is also, to me, very important as long as it's used the right way. And using it like with compression is even better. But ice has been shown to, first of all, to cool the skin. It diminishes your feeling of pain, but also has been shown to diminish the small peptides in your joints that give the feeling of pain. That's substance P is diminished if you give enough ice. But ice can also burn, so you got to use it the right way with a moist or a dry thin cloth in between a bag of ice and your skin, and then you compress it and you add elevation to that. It's all synergistic. Voluntary behavioral modification, I like that one as well. If your knee hurts, don't run on it. If your shoulder hurts, don't carry your bag on it. And if your wrist hurts, then don't use the mouth with that wrist. So that's voluntary behavior modification. But by far, my favorite one is exercise. So exercise has been shown time and time again, as long as it's the right exercise, done the right way, at the right time, you're most likely going to overcome some of your pain. So what are the benefits of appropriate exercise? Well, they're irrefutable. From time and time again, the right exercise done the right way does diminish a person's feeling of pain. Doesn't mean it gets rid of it forever. Doesn't mean it may, but I believe it can make it go from a, let's say, a level 6 to a level 4, or a level 3 to a level 1, or level 10 to a level 5. There are benefits to the right exercise, and it can combat chronic disease. It can slow the progress of dementia. Elevate mood, increase energy, prolong independence. You might not need that cane if you have exercise on your side and you know which one to do. The most important thing is you do it. People have to do it. Your patients have to do their exercise. If they don't, they're going to fail, I think. So alleviating pain, of course, reducing falls. And falls, as we know, as we age, is horrible. It can change somebody's life. Whether you break your hip, dislocate your shoulder, or have this traumatic brain injury, you might never be the same from simple fall. And you can fall from a standing position when you're over 50 or 60 and your bones aren't strong, or your muscles aren't thick and firm. You might fall, break your hip, and 28% of people are dead by the first calendar year after you break a hip. So you don't want to do that. And I think with the right exercise done at the right time in the right way, through motivation from people like you who see them when they're recovering after injury or even after one fall. A lot of people, they fall, they break their wrist, but they didn't break their hip, and they come to see you. You say, hey, you had a fall, you broke a bone. That means you might have a little weakness in your bones. So please do your right exercise for your balance, your strength, your flexibility, so you don't fall. And ultimately, it can lengthen life. And I think that's important for a lot of people want to live longer for some reason, whether it's family, whether it's just the joy of being on earth, or whatever it might be. So I founded this company called PopDoc many years ago with a doctorate of physical therapy, and we have an exercise scientist now on the team. And because some of my patients after surgery, they were just not getting the right guidance, the right knowledge, and the right action items that they needed. So I put together a database of now it's probably over 800 exercises that are prepackaged into about 800 different groupings of exercise. And I think technology is here to stay. If there are some patients who are not afraid of it and they want to utilize it as an adjunct or a supplement to the formal PT they are getting in the hospital as an outpatient, or even if a PT comes to someone's home, I always like to tell patients, well, it's a 7-day week and the PT is 2 or 3 times a week. So you have those other 4 or 5 days to do something. So I hope there's something that you guys are offering something to your patients. So this is health and wellness technology. I like to call it corrective exercise therapy software. These days I'm focusing on the fascia system, which is really more than one joint in more than one plane. So it's a full kinetic chain exercise therapy software that if someone has a sprained ankle, we can also work a little bit on their hip and their knee musculature to help them kind of stabilize their ankle. Same thing with their shoulder or their neck or their back. So it's accessible from your phone, laptop, tablet, desktop, or TV. In addition, any of these exercise groupings can be printed out from a PDF. So if those people do not have access, then they can be printed out. And the right exercise is done the right way, in the right order, leads to success. That's success for your patients. If the patients love what you bring to them and what you do, they will refer their friends and family to you. less pain, more ability to do the things you love. I think it's an important underscoring the why. Why do we do this? Why do we, as physical therapists, why do we try to help people with their pain? Ability to like enjoy life as much as possible by gardening, dancing, hanging out with their kids or grandkids, or just doing the things that make you feel good. Fully customizable to meet and fit the needs of your people, as Morris was talking about before. There are clinical pathways and clinical guidelines. We have them in orthopedic surgery as well, but doesn't mean that all patients fit into them. So if you need to help a patient in a different way, we have some adaptable exercises that are a little easier or a little more, straightforward or less stressful on the joint. So software that meets you where you are, increasing the quality of your neuromusculoskeletal system, incorporating the neurological component of your musculoskeletal system to get better outcomes. So it is a unique and effective platform. For instance, for knee muscle toning, the mini wall squat, this is kind of how it looks as a version 1 system, where there's GIF animations, tells you how to start, how to finish, technically quite precise. It's also written in Spanish or English, and there's also voiceover for many of the exercises to help people who can't see as well or need some assistance. Simple, easy to follow, text is either English or Spanish with voiceover. Uniform images with a human model. She's a doctorate of physical therapy. She's a partner in the company, and she also is helped me recover after, let's say, ACL surgery and shoulder surgery that I had in my life. And it is effective at diminishing pain and maintaining function. So it is impactful. The subscription service for both individuals as well as families, home care agencies, independent or assisted living facilities, physical therapy companies, senior centers, community centers, tracks and monitors end user usage, engages, motivates, and empowers people, the elderly, and those that care for them. So we have some nudging and some emails that can go out to users of the system. So and these are all customized messages that go out from your clinic, and they go to the patient and says, "Good job. Exercise is important. I'm glad you're doing them at home." Or if they haven't been doing it, say, "I think it's important that you at least do a little something to help you achieve the best outcome as possible." We integrate easily and opens communication between caregivers and families. So the key results from integration of the PopDoc platform: easy to use, engaging, and effective, accessible nearly anywhere, attaining, maintaining, and preserving healthy joint function, keeping you and others independent and social, feeling less pain, improving the quality of your life. So together we are stronger. So we come from experiments. We're built on integrity. We offer clarity and execution to help give action items to your patients so they can have the knowledge you give them, have the guidance you give them, and then have the action items to keep them on task, to keep them doing things to help them stay as independent as possible. Doesn't have to be too long and cumbersome, 5 or 7 minutes a day to help positively change people's lives forever. So what about HealthSpan? HealthSpan is a quick term I want to just bring up because it's about living on this earth, but that's called lifespan. But it's really about living on this earth in an independent state. That means doing those things that bring you joy. And it's not only exercise like strength, balance, and flexibility, but that should be a daily part of your life. However, there are other things that are borne out in the literature, in the data. Getting enough sleep and rest, whether you're working out and you want to give your body some time to rest and recover, or getting enough sleep every night so your body can rest and recover. Very important, both of them. Hydration. About 70% of Americans are dehydrated. So hydration, I like to think of it as the motor oil for your car. Keeps the organs flowing nicely. If you don't have hydration, your organs get stuck, and you can get kidney failure, or you can get a heart attack, or you can have some GI issues, and even your brain, if it's not hydrated well, can become thickened up with tangles, and you can stop thinking the way you want to. So diet and nutrition, I like to lump them together, even though they are a little different. One of them is like what you take into your body, and then the other one is the quality of the stuff you put in your body, quality and quantity. So it's what, and then it's how much, and then it's what's the quality of them. And now with nutritional supplements, there are some things it's hard to get from your diet in America because the soil is so depleted, and some of the hormones and pesticides and herbicides and antibiotics that some of our food is given, diminishes the nutritional quality and alters the diet in a negative way. So being really mindful of what you put in your body, if you can, that'd be awesome. Minimal vices, so smoking, drinking, drugs, for sure. So those things have also been shown to increase cancer rates, diminish your cognition, and ultimately diminish your health span. Mindfulness, being able to, everybody gets depressed at one point or another, whether it's a minimal thing where you kind of go down a little slope, or do you go down a big mountain and you're like really bummed out. So it's part of life. Something might just set you off, and then you need to have that mindfulness where you can go to the deep, dark parts of where your world is and then bring yourself back up. And it might be through sociability, that last point there. Or it might be some, you might have some good mind control or some family that you're close to, but sociability has also been shown as a very strong indicator of how long of an independent life you will live. So if you're a loner, there's just more chance of depression and like not having those things to let you live long. Sociability, to me, is very important. So just going out and saying hello to people and just finding other humans to connect with are all part of your health span. And I think that, people on this call, they probably all want to live a long life because the earth is a great place to be. But also they might have friends and family and clients and patients that they also want to influence so they can also rise up and achieve that health span. Thanks so much for connecting with me. I believe strongly that healthier joints make happier people. So I'm going to stop sharing this. I'm also going to, put a little something in the chat in case anybody wants to reach me, because I think in this world we live in, there's where am I here? There's always room to connect. I love, connecting with people. I'm also, I don't know how much time I have. Jenny, how much time do you want me sitting here chatting with you guys?
Yeah, you can have another 15 minutes, Dr. David. You're until 6 o'clock, but you can devote this now for your QA. Even we have some questions already. Yeah.
Yeah. So give me 1 second. Let me share one more thing with you guys, please. And what do I want to share?
You're until 6, Dr. David, including
Cool.
your QA.
All right, give me 1 second. Let me do something here. I thought I had set this up nicely. Bear with me 1 sec. So I want to just quickly, if I may, just show you a little bit about the website. So this is the homepage of the website. I'm logged in as an administrator right now. This is that's at popdoc.com. A sample exercise like the one in the slideshow. It's all in English or Spanish. There's GIF animation showing you where to stop and start and where to stop. Very technically precise. There's not a video that someone can get lost in, because I believe that sometimes you turn on a video and your mind goes to the person doing it instead of your own body. So I think having GIF animations is helpful. I go to the administration dashboard, for instance. I look at these exercises. So the exercises currently on the site, they're about 645 exercises. So it has every body part. I recently put in some hand and wrist stuff for any OTs, but all exercises are set up the same way. And then the exercise groupings that I've already put together, which are all customizable. So the exercise groupings, there's about 680 up here on the site. And for instance, if you see somebody who you want to have them regain neck motion, so they become stiff as their main issue, then all of these exercises can be given to them. Each of them are customizable. So if you look at one which has a specific, just a roll under the neck for some elongation of the spine of the neck, all this text can be altered and amended and customized to you. The title can be also. The order of these exercises can be customized. You can add or subtract exercises as you want to. And some of the new functions on the site are these the configuring surveys that get handed out to the patient online, of course. Then it can be 1 to 5 questions just to get some feedback. And you actually build data that you could use for remote therapeutic and remote patient monitoring for Medicare and Medicaid here in the USA. That if they are on, they do their exercises, they complete surveys, they have someone in your office communicating with them and documenting it in the medical record, they can get reimbursed for this type of treatment or this type of care. User notifications, those are SMS or those are SMS or email notifications, of which they can all be customized, like a reminder, like if they're exercising or they haven't been exercising for a couple days, we can make custom exercise reminders that we can support them with love and say, hey, you know, exercise is important. I think you're going to feel better if you do them, so just do them. And then there's the email content of any email notifications that we assigning exercise groups. When you assign an exercise group to someone, they might get these kind of messages, and they say, here, you know, popdoc.com, start making your move to better joint health and all those good things. So we want to be an asset for you. We want to build value for you and the things that you do for your clients and patients. So if you are, so I see a Dr. Netherine ask me the pricing. So pricing, I always went into this with saying, okay, joint health should not be very expensive. So for instance, doc, if you are a physical therapy facility, that means it's like you're a business working with my business. So it's business to consumer. The consumer is the patient who's consuming the exercises. It's about $1 per patient per month. So the minimum amount is $15, and that allows you to have 15 patients using the system. Whether they use it 1 time or 100 times, whether there's 1 practitioner or 20, doesn't matter. It's $1 per patient per month. It's very reasonably priced. So if patients leave your practice, you can take them off the list and you can put on someone else. But if you have, let's say, 100 people per month, if you have 10 facilities around, you know, the state or country or wherever you are, and there's 100, it'll be $100 for that month. So it's $1 per patient per month. So that's very easy to understand as a business. As a consumer, it's more like it's like $6.99 a month, allows you to get 5 exercise groupings that you can use, and you can switch out as much as you want to. Yes, you're quite welcome. Are there any other questions I can entertain? I know I have a little time left, but I talk quickly and want to give you guys the opportunity to, you know, speak with me if you want to.
Yes. Dr. Newman, there's a question from Marie, and she asked if after the transposition of the ulnar nerve, which one is best to address the rehab? Is it PT or occupational therapist?
Well, the ulnar nerve travels, you know, from your neck down into your armpit, down to the medial aspect of your elbow, down into your medial aspect of your wrist. So sometimes it's operated on here, but a transposition is mainly at the elbow. I don't know if you can see my elbow, but at the elbow. So I think it's a good question. And I think that, to me, occupational therapy has always been function based. Like, can you pick up a glass? Can you pick up a frying pan? Can you do things? When physical therapy is like, let's just get you back your motion and diminish your pain and get you back your strength. So I'm more of an advocate of a nicely mobile joint or extremity with good strength allows you to function outside the realm of your daily activities. Like, let's say you want to pick up gardening or cooking or painting, and you can do that if you have good strength and good motion of your joints. Well, I believe that I personally, and other people might have other opinions, but I think that for people going back to work, occupational therapy is good because they have a specific tasks they have to complete successfully while at work. But if someone's going back to life and want to be like a fully functional human who is enduring whatever they want to and taking up bicycle riding or painting or whatever, then physical therapy is the one that really kind of allows you to get more out of your treatment. But that's just, like I said, that's my opinion, and I know that some other people might have others. Oh, it's interesting. I see that I potentially only sent this to one person. Yeah, so maybe I'll try this. Boop. Boop. There we go. That's to everybody. So I'm happy to connect with whomever wants to. I have certainly a bunch of physical therapy facilities that are using the system, and the system's always getting better. And I'm always open to feedback to learn more from the people who use it, because I want this to be an asset to you, to bring value to your patients and to your business. I don't want it to be a big spend for you.
All right. Thank you so much, Dr. David. And do you have like demonstration, or like whenever they want to learn more about the home exercise platform, that they can chat with you and you can show, or do they have like 10 days, 1 week trial just to play with it?
Well,
Or
it's yes,
questions?
it's a good question. Thank you. I'm happy to connect. I'm happy to give a webinar to any practicing physical therapists and their staff, whether it's a PT aide or their whole staff. Because sometimes in some facilities, the administrator who checks people in and out, the doctor gives them, say, hey, send them some exercises, and the administrator who works with the office has access, because they're a user of the system. They can send the patient the exercise groupings, and it's all pretty straightforward, and I'm happy to discuss that and have a webinar with whomever. But the price is so reasonable that there's really no, some people can cancel any time. It's like $15 for 3 months to see if they can incorporate it into their practice, if their patients can like use some exercises, get some feedback to them about how they like it or don't like it. So I think it's reasonable enough.
Thank you. So Marie just had a comment, excellent opinion on PT versus
Thank you.
OT. All right. So thank you guys. So we're done with Dr. David Newman, but definitely Dr. David, please put your social media down on the webinar chat, or your link where they can connect definitely with you. Okay. All right.
Yep.
Thank you.
Sounds great.
Wonderful,
Thanks
guys.
so much, Jenny. I appreciate the opportunity to chat with you guys. Keep making a difference in the world, and as you age, do it gracefully.
Yes, thank you. That's why the title itself, How to Age Gracefully, and that's always the common goal. Yeah, so we really love and appreciate your input, Dr. David. So definitely we would like to thank you, and we would like to share this with you, Dr. David Newman. Please receive our certificate of appreciation and accept this. Thank you for sharing your knowledge and expertise for this summit with us. All right. Thank you.
Thank you. Thanks, Jenny. I
You're
appreciate
welcome.
that. It looks awesome, that certificate. Thank you.
Yes, and thank you as well, Dr. David Newman with PopDoc is one of our sponsors. Some of you are here, came as a beneficiary, as a silver sponsor from PopDoc. So thank you so much, Doctor. So Dr. David explained to us what is it, the home exercise, how definitely in addition to your as a database. All right, so connect with him. He will put it on the chat to learn more. Thank you, Dr. David. Some of the attendees here are part of your beneficiaries. We appreciate you.
Awesome. I appreciate all you guys. Thank you.
All right. So guys, we can have a 5-minute break, and we will have our next speaker. So you can just take a quick pee break, so you can definitely stretch, and we will go ahead with our next speaker. Okay. All right. For our next speaker, we have Mark Evan, a co-founder and CEO. And because we are global, he is coming straight from Canada. All right. 5 minutes break, guys. Thank you. Yes, you go ahead. So 5 minutes. I'll see you, yeah, around 5 minutes before 6 o'clock. So maybe that's
You know what happiness is to you. Clap along if you feel like that's what you want to do. Clap along if you feel like a room.
All right, guys, get ready for our next speaker. All right. So as was I said, we have another great speaker, and Mark Evan is a co-founder and CEO, and he is based in Canada. And he will going to discuss about leveraging gamification and virtual reality toward increasing motivation and physical activity. So this is amazing one, and we would like to learn more with him, okay? But who is Mark?
Hello, everybody. Excited to be here. Do just give me a thumbs up. You hear me? Okay.
Yeah. Wait, Mark, are you in already? Give me a second. Let me introduce you quickly. And
Okay.
then I will give the floor so I can make you a pin, and because I cannot see you right now. All right. Give me a second. So guys, Mark Evan is the founder and CEO at Ludica Health. So he is the founder of the LudoFit. He will going to learn more. We will going to learn more about him. And he is the Ludica Health's flagship product is the LudoFit. And Gentronics is currently being used in over 300 rehab facilities in North America. Mark led the company through Gentronics' initial design, IP, clinical research, regulatory approval process, and market development. Ludica Health's newest program, LudoFit, is an easy-to-use therapy software for laptop, iPad, that enables therapists to assess, train, and track progress for strength, balance, endurance, coordination, and cognitive skills. So these are amazing. For this summit, we will learn more great innovation and stuff that we can use the next day on Monday. All right. All right. I'm giving you the floor, Mark. Thank you so much. Okay, let me see. Where are you?
Okay,
I
excellent.
can,
I'm just going to
yes.
share
All
my
right.
screen.
Mhm.
And okay, you see my screen?
Yes.
Okay, excellent. Well, thank you so much for I'm very excited to be here, and thanks for coming and for attending. And I'm excited to tell you a little bit about gamification, VR. I've been in this world of physical therapy and technology for physical therapy for almost 15 years. I've created several interactive programs, and each program has gotten progressively more interesting, innovative, interactive, and portable. And I'm excited to tell you all about this space, what types of technologies are out there, what type of how it works, and on the scientific level, on the psychological level, and on the clinical level. So let me go right into it. And I'm going to start by giving a little introduction to our company so you know where we're coming from and what we do. So we were founded in 2012. It was actually came from one of our co-founders. His father had actually suffered from a stroke, and that created the catalyst for using interactive technologies for really turning therapeutic exercise into something fun and engaging for individuals. We primarily combine video game experiences, evidence-based exercises, and interactive motion sensing technology. We have a few programs that we've brought to the world over the last 10 years. Our flagship program, as Dr. Jenny mentioned, is Gentronics. It's in over 350 rehab facilities around the world. It's an interactive kiosk. It's mostly in skilled nursing facilities. And our newest program is a LudoFit and LudoFit Pro. And that's going to be the key elements I'm going to be talking about today, because these aim to bring these cutting edge interactive therapy exercise experiences to people in a way that's, as you'll see, much more affordable and really portable. So we'll get right into it. I'd also want to mention that we have a number of clinical studies, clinical research that has been performed on our different technologies. They've been published in a number of really well-regarded, highly respected journals. We work with academic institutions, both in Canada and the United States and Australia and Singapore. And the studies have shown improvements in different areas, including physical activity, gait speed, general engagement, quality of life, and mortality specifically. So that's a little bit about the clinical evidence that underlies what we do. When we develop programs, we really pursue an evidence-based approach from the design stage to the development of prototypes to the testing, and then even after, we're constantly iterating on what we do. So today, what are we going to cover? We're going to talk about the art and science of gamification and play in therapies. So we often think about play in the sense of something that's non-goal oriented, something that doesn't provide any specific benefit, that's something that maybe is childish. And what I really want to talk about today is some of the fundamental some scientific evidence that shows what play is at a deeper level, both in terms of the functioning of the body and of the psychology, and how that relates to clinical outcomes. So we're going to go into all of that. Bridging clinic and home. So how do we use these types of technologies both in a therapy setting, whether it be outpatient, skilled nursing, inpatient rehab, home health, and bringing them to patients and having patients use this in their homes, and also having that bridge, so being able to track and monitor patients' progress. And then finally, I'm going to give you guys a live technology demo. So you're going to see our latest program in action. I'm going to talk about how it all works, and I'm going to go step by step so you can see what this is all about. And hopefully this will stimulate some ideas and questions. And I'm looking forward to answering and engaging with you. And we will go from there. So let's start with the art and science of gamification and play. So how does it work? How does play fit into everything we're talking about? So we're going to look at the difference between simple leisure, so non-goal oriented play, and therapeutic play. We're going to look at the impacts of play on stress hormones like cortisol. We're going to look at leveraging familiar activities to enhance procedural memories. We're going to looking at different areas related to fear, anxiety. We're also going to look at different types of play-oriented technology, specifically in relation to fully immersive VR, which is probably what you think of when you think of virtual reality. You probably think of VR goggles, and then there's semi-immersive VR, which is what we do. And I'm happy to talk a little bit about what that is and show you. So let's start with a quote from Primal Play. So it's not just fun. This is serious stuff. When we engage in play, we activate parts of the brain associated with pleasure, creativity, problem solving. It's a natural and necessary mental exercises that keeps our brains flexible and youthful. Play is a critical part of who we are as humans. We play every day when we talk, when we have fun with our colleagues, and when we play with our friends, we play with our kids, we play with our parents. Play is not even just human. We see play across many species. So what is play, and why is play so fundamental to what we do? So let's talk a little bit about the physiological elements, or what role does play in the on the stress response system. So let's just take a quick look at what happens when we feel stress. So you guys might be aware of cortisol, which is known as the stress hormone. When a person feels stress and anxiety, that emits cortisol to the rest of the immune system, and that's actually an important reason why when we feel stress, over a long period of time, that affects our immune system and we tend to get sick more often. But not only that, there's a cycle, there's a system, there's a feedback loop. It's called a virtuous cycle, not in a good way, in a way that just self-perpetuates. Cortisol emits, the hypothalamus of the brain responds to the level of cortisol, which then emits hormones that are relation to that activate the pituitary gland, that then continue the cycle of releasing the adrenocorticotropic hormone, which then emits more cortisol, and that cycle continues. So that's a really important part of looking when we think about play. Let's first look at, well, what is the system that play is here to really affect? So this is what's going on, and let's look at starting at the physiological level. So when a person is engaged in play, there's a few things that are happening that interfere with the stress response system. The first thing is the release of dopamine, which can inhibit the release of the CRH hormone up here. So when there's dopamine, so that could inhibit, that could reduce the power of this feedback loop. The second thing is the production of endorphins, which is the body's natural painkillers, which could reduce the intensity of the cycle in its completeness. So that's a really key part of what play does at that neurochemical level. Play activates pleasure centers, so it stimulates areas of the brain associated with pleasure, such as the nucleus accumbens and other areas. And then finally, that reduction of cortisol. So that's fundamentally what play is able to do at a physiological level, is to really result in the reduction of cortisol. And an important hormone related to that is the ACTH hormone. And that is the key part that is often referred to in terms of a virtuous cycle. So that regulates the cortisol hormone. And when you're able to get control of that or able to interrupt that flow, you can really affect the stress response system in a positive way. You can really reduce it. So it's a really important piece, and this is an important hormone to keep in mind. There may or may not be a quiz question related to it, so just a little clue. And then let's look at the psychological level. So play relates to psychological buffering. So not just at the neurochemical level, when the person is able to build resilience to stress, that could then reduce that stress response system. So that's more higher level psychological functioning. That is really important to that. And then there's cognitive flexibility. So often what contributes to the intensity of stress and the stress response system is the feeling like we're a little bit, things are a bit out of our control. And then when we're able to activate parts of the brain related to creative thinking, related to problem solving, that has the effect of reducing the overall intensity of the stress response system. So these are the key pieces as to why play is not just specifically therapeutic play when it's done right. It has a really critically important effect on stress and on results when it comes to achieving clinical outcomes. So we're going to continue on, and we're going to talk a little bit about procedural memories. So when we talk about procedural memories, what are procedural memories in general? We call them sometimes motor memories. You may hear about the term automaticity, which is when the body is able to perform actions or processes automatically without conscious thought or effort. Also referred to as procedural memories, motor memories. So when we are able to bring to the patient experiences that are not even experiences that they've had lots of experience with, like let's say, whether they've skied or not, but they understand what it means to ski. They understand what it means to reach for an object. They understand what it means to climb up, you know, a rock wall or something like that. These are memories that we have that we associate, and then we can combine those with motor tasks. And that is used when you do that in a way that has that feedback loop. You can then use that to increase procedural memories. So that's another really important part of how play in particular is integrated into can be integrated into therapeutic exercise in a way that's really beneficial. Okay, so we're going to continue, and we'll talk a little bit about technologies. So there are different types of technologies that serve the function of play. And the one technology, as you guys are probably familiar with, is fully immersive VR. And probably a lot of you may have had experience with that in your clinical setting. They're usually focused only in the clinical setting, not really for home use, but in a clinical setting, it's sometimes is used. It's where, you know, you use a classic virtual reality headset. You have the fully immersive space in all directions, sight and sound, and you are completely disconnected from the real world and fully immersed in the virtual world. Now, on the level of immersion, that definitely has the highest level of immersion. We call it fully immersive. You're completely in the virtual world, but it does have its drawbacks, and we're going to talk a little bit about that. The other type of VR that is something that we do a lot of focus on is semi-immersive VR. So it's not, you're not completely disconnected from the world around you. You still can see everything, your immediate space. You still have that orientation of you to the world around you. But one of the key differences is that you're connecting with the virtual world through a device, whether it be your laptop, whether it be your tablet, and the program is able to sense your motions through your web camera or other types of motion sensing mechanisms. So that's the key piece of semi-immersive VR. And what are the key? There's a lot of similarities, of course, when it comes to both being able to integrate these playful experiences. But what are some of the differences? Well, relating to the key pieces that we think place semi-immersive VR in a better position in relation compared to fully immersive VR is around safety and orientation. So when an individual is engaged with a semi-immersive VR experience, they still see everything around them. They are still connected. There's no risk of nausea or elements like that. There's a true, there's a full connection to the real world that they're in, and they have the screen in front of them. So it really allows the same level of engagement, but the level of risk, orientation, safety, those and the fear of technologies that we've found that to be quite a bit lower. So from our perspective, as we develop our technologies and we've experimented with all different types of VR and motion sensing and interactive technologies, one thing we found is that the semi-immersive VR is really well positioned to be a good tool for the clinic as well as for patients at home. So that's a little bit around where we're at on the semi-immersive versus fully immersive piece and the different technologies that are available. And then let's just look so you can see a little bit about what this is, what we're talking about when we think about semi-immersive VR. This is a clip from the LudoFit program. You can see that we're in a rafting environment. You have the individual standing or sitting in front of their device. The program is actually tracking their motions with their web camera, and their avatar their movements are projected onto a screen through their avatars. So as they move their arm in the right side or the left side, the individual on the screen, the avatar on the screen is doing the same. So there's that interactivity, but you can see that this individual is fully present in their physical environment. So that's a little bit about what play does in terms of associating movement with enjoyment, fear rather than stress, and the results that could come. So and we're going to continue, and the next piece I would like to talk a little bit about is biofeedback. So that biofeedback, we think of biofeedback in different ways. There's physiological biofeedback, heart rate biofeedback, and different types of biofeedback. The type that I'm going to talk a little bit about today is around the physical movement level. So what does play do and what does interactivity do? How does that contribute to the biofeedback loop? So first, let's just look at the biofeedback loop and what it is and how it works. So the brain issues motor command to the muscles, which then affect the effector organs. They have a functional outcome, whether they succeeded or failed. So let's say there's an object on the screen. They reach, they see their character on the screen doing the same movement. They can assess, am I doing the correct movement or not? And then they could adjust. So that is a concept called the Hawthorne effect. And we'll see another example of an individual engaging with the program. So you could see that this is a static standing balance exercise. So this individual is in a ski environment. And basically what he's doing is he's navigating by weight shifting to the right, weight shifting to the left to get through this ski course and squatting underneath the branches. And you could see he's moving. When he's squatting, he's able to see, am I squatting deep enough? Am I squatting deep enough for this task? Now, I should be very clear that all of these activities are customizable. And when I go into the demo of the program, I'm going to show you how you're able to customize these programs. So an individual who has limited movement, who only needs to do this, who only can do exercises in seated position, are able to still participate. So that's a really important piece of it. And biofeedback is really about seeing your movement, watching the effect of your movement, and then correcting your movement. And that cycle goes, many repetitions a second when you're engaged in a real-time program that does this type of interactivity. So we're going to move and we're going to talk a little bit about the clinic to home. So there are different ways you can use a technology like this. You can use this program both in a clinical setting, and I'm going to show you how that piece works. And then you can also use these types of technologies in home, and we're going to talk a little bit about the advantages of using a program like this for home, and how it could be used and why. So let's continue. All right, so first of all, let's talk a little bit about why. Why are we looking to increase physical activity at home? How and why? So let's talk a little bit about why. What are we doing this for? This is important because when we send a patient home to do exercise, we can check the box and give them certain types of exercise. But if we really treat the importance of the exercise adherence, the compliance, the engagement. If we want our patient to come back feeling better about themselves, feeling more advanced, feeling more confident, then giving them an opportunity to have fun while they're doing it, that becomes a really important piece. So we're talking about tissue hygiene when it comes to resistance, endurance, time under tension, taking on a little bit of a greater load of tension as they go. So tissue hygiene relates to maintaining the health of their tissues, such as muscles, tendons, ligaments between therapy sessions. And then there's self-efficacy for physical fitness. So one of the key pieces related to to a person's ability to progress in their rehab journey is feeling like they're progressing. And that's another type of feedback loop, is when I don't feel like I'm progressing, that affects my psychology, and that affects my my likeliness to really step in and engage the next round, the next week. And so feeling like you're making progress is a really important piece. And that's important. That's one of the key reasons why home exercise is so critical. And then associating movement with fun. I mean, we talked a lot about fun just previously, but having that piece in a really important place, having that fun element, and really, for a lot of people who aren't athletic, or had many athletic experiences in their life, often tend to associate exercise with stress, and that has a different type of cycle. So we really want to kind of connect exercise with fun. And then there are different types of home programming. We won't go into that. There's, as we've heard, there's images, video, and today what we really what I want to kind of tell you about is really focusing on these interactive experiences and really bringing that part of that into a patient's life. So let's talk about, when we're bringing physical activity to patients, how can we ensure success? Well, there has to be less friction. There has to feel convenient. We have to receive some form of reward, and that's where the gamification piece is so important. We have to see ourselves improving. So that's a key element around self-efficacy. It's more likely to be adopted when it seems playful, when it suits our identity. So that's another key piece. And when we have autonomy. So autonomy means, having the ability to have control over what I'm doing, how much intensity, and those elements. And this comes straight from a number of clinical pieces and studies. So what are some of the core barriers? Making it easy, obvious, attractive, satisfying, the endowment effect, creating elements where you've earned something, whether it be badges, whether it be points, whether it be personal bests, something that you've been given that you want to keep. The lack of autonomy is a problem. We have the same program for everyone. What we're looking to do is create more personalized experiences for people. And then we talk about the atomic habits, which is a lot of where some of the evidence comes from. And then in terms of the endowment effect that we talked about, earning something that you want to keep. So in our programs, we really spend a lot of time and focus and energy creating an experience where they see where they were, what their personal best was, how they've done over the month, where they're looking to go. And I actually just had a conversation with one of our users yesterday, and she was talking. We had a really returned actually into a brainstorming session about all the other newer ways that we can bring that element of goal setting and goal achievement to an individual. So that's around that. And then the endowment effect, again, achieving your personal best. So in a program like this, that's a really important piece. In terms of autonomy or lack thereof, so a lot of people are interested in wanting to decide which way, how much exercise, how difficult. Interactive programs like the program we built gives you an opportunity to, after every exercise, to rate your level of effort in the activity, and to increase the challenge level and to unlock new challenge levels and really, move to where you're moving. Okay, so that's a little bit around, what these types of programs are. And I'm going to go into a technology demo. I'm going to show the LudoFit Pro program. So I'm going to go ahead and share my screen. I have to make a quick little change, make sure you can see that. So give me a quick second here. Okay. Oh, by the way, I saw just as I'm going, I see some questions around games for wheelchair-bound older adults? The answer is absolutely. This program is designed could be designed for seated position, for standing position. So you definitely can do this program in a seated position for wheelchair-bound individuals. Could be done with wheelchairs, with walkers. So that's a really important piece, and I'm going to show that in this demo. So I know there were some other questions, but I just happened to quickly see that one as I was doing this technical change. So what are we doing here? We're looking at the LudoFit program, the LudoFit Pro program for therapists, and I'm going to go ahead and log in. Okay, so now that I've logged in, I'm going to take you guys step by step through the program. I'm going to show you some of the activities that we have, and then we will go from there. So I just logged in. I have my list of patients. These are all kind of they're demo patients, so don't worry about that. I'm going to go ahead and click on a particular patient. So here I am. I just clicked on the patient. You can add a patient very quickly. So this is the August. So this tells me about, first thing it says from a patient perspective is like, how am I doing on the cognitive side in terms of arms, legs, core, and you can see with each element or each clinical goal area from the patient's perspective how they're doing, where their badges are at, and what their goals are. They have a program that's presented to them based on their past activity. You can continue the program or you can browse the exercises. So what I'll do right now is I'm going to go and click on browse here so you can see the different exercises. So I'm going to quickly go through each of them just so you can see them, and then I'll play a few of them so you can see them in action. You have standing position and you have seated position. So that's important from the therapist perspective to you can adjust that and all the games will be. So for example, we have a weight shift and squatting exercise for balance and lower body strength. If you click on seated position, that then becomes a trunk flexion game focused on balance and core strength. So those are the different ways. So ski the Alps, focusing on that, Thai rock climb. So each experience takes you to a different part of the world. And that's part of how we conceptualized this program, is combining some of the things that older adults love, which is the world travel, going to places. And we really did a lot to include that as an important part of combining that with therapy exercise. So Thai rock climbing, you're in Thailand, you're scaling the luscious rocks of Thailand while focusing on dynamic balance, sidestepping, and reaching. Tour de France. So this is a game that's focused on marching in place, knee raises, focused on cardio and dynamic balance. A lot of these activities are full body experiences, so they're meant to engage different parts of the body. It's also meant to be moderate exercise, so you're not going to be pooping yourself out, to use a informal term, but this is meant to be moderate exercise. Trunk flexion. So this is a New Zealand experience where you're basically controlling the movement of a ball with the tilt of your trunk. We have a rafting in Chile, which I think you saw a little video of. So this is focused on upper body strength and functional reach. So it's bilateral exercise that could be done in single arm or bilateral. We have a new game also. This is a Explore the Temple, which recently we found that this is a lot of our users' favorite game. It's a dual tasking game. So all these exercises come from the clinical evidence, specifically the Otago Fall Prevention Program and Tai Chi Moving for Better Balance. These are exercises and other specific key clinical evidence bases. One of the key areas, and the reason I'm bringing that up, is because dual tasking is a really important part of fall prevention, and it's very hard to do dual tasking, without technology. That's just even going beyond the element of play. So let me start. I'm going to start with one exercise, and then we'll kind of do a few, and then I'll show you some of the clinical data at the end. You can see what the performance data looks like, and we could talk a little bit about the user flow, because it's one thing to think about the program, but then thinking about, well, how do I actually integrate this into my practice? So here, once you click on the activity, you can decide seated or standing. You always have the choice to change the duration. So I'm going to just put it for 2 minutes. Challenge level between 1 and 10. Now you can have the patient do a strength test, which is the 30-second sit to stand test that's administered automatically in the program. I can show that maybe later, depending on if we have time. There's a lot I do want to show and explain, but we might get there. So challenge level, I'm going to just do challenge level 5. I'm going to start. Okay, here we go. So it's polishing the skis. You know, that's really important. So let's give it a moment or two. And we're going to go into the activity. Now you can see here the difficulty level. This is, by the way, the Italian Alps.
The slalom game focuses on
I'm going to
hip.
pause here for a second. I want to make sure that you may or may not hear sound. Maybe, Jenny, if you can give me a little thumbs up if you do hear sound. I just want to know. Okay.
We hear the sound.
Excellent, excellent. Okay. So every activity, one of the key pieces is, is this usable? Is this something that's easy to use? That's actually a fundamentally important piece when you're developing a program, especially for older adults, especially something that is a little bit more advanced than, say, you know, a YouTube video. So every activity before you go in, there's a little video. I'll show you this video. I won't show all the videos, but this is a 1-minute video.
You'll be skiing the Italian Alps, and to move your skier to the right, you're going to shift to the right. To move your skier left, you're going to shift your weight to the left. Your lower body is doing all the work, your legs and your hips and your knees, but the upper body stays upright. You may also be challenged to ski under obstacles. Again, make your legs do the work. So you're going to bend at the hip and the knees to go under the obstacle rather than...
All right, I'm going to pause there because I want to make sure that we have enough time for everything. But that's the video here. And I'm going to go ahead and continue.
Please move back.
So the first thing it does once you start the program is it tells you to stand up and move back. And here you see me over there on the screen. It tells me basically I want to align my body with the silhouette on the screen. So I'm going to go ahead and stand up.
Please move towards the center.
And you can see basically here I am, and I'm standing in front of the program, and I need to move my body into that little silhouette area. So it's very simple. So I basically sidestep, I get in the area, it asks me to move a bit back.
Now hold still.
Great, hold still, I'm ready to go. So that's it. I'm basically, what am I doing? I'm standing in front of the program. By the way, I just actually want to pause for a quick moment to say one little disclaimer. So you guys are seeing this on Zoom, and I'm sharing my screen, so I know it's going to look a little choppy. It's going to be a little choppy, but you're going to have to use your imagination to know that when you're playing this game for real, it's quite a smooth experience.
Please move back.
Okay, with those housekeeping items aside, here we go into the program. So what's going on here? I'm in the ski activity.
Try to aim for as many stars as possible.
You can see me at the bottom right. So there I am. Hello. And now what am I doing? I'm simply shifting my way to the right, shifting my way to the left. So this is static balance. As I go, I have a choice. Can I go to the right?
Remember
I go to the left. This is all about patient autonomy. Giving patients choice, we actually created a full ski the Alp environment. So there's a lot of different directions they can go, and so they really, don't get bored. So here I am doing weight shifting, focusing on my hips, focusing on my knees.
Squat.
A little squat. So a little squat is all I need. In this particular, I'm at level 5, so basic squat. Here I go, another choice. So do I want to go to the right? Do I want to go to the left? Okay, I'll go to the left, continue along my way. And here I am, shifting my way to the right and to the left. I'm halfway there. And I won't go to the entire game because I do have a lot to show. But here I am in the mining tunnel. So I will continue along. And okay, so I'm going to pause on this game. Oh, look at that. I got a personal best. Good for me. excited about that. It's really full of full of positivity, full of motivation, full of joy and play and clinical evidence. Bringing these pieces together is really important. I'll go ahead and finish the activity.
Click on the number that corresponds to your level.
Okay,
of
so what are we
exertion.
seeing now? So this is basically rate your level of effort. This is where the autonomy piece comes in. So let's say I thought, okay, that was, let me rate it. Let's say it was a bit easy.
Got it.
Okay, so it asks me if I want to personalize my level with the 30-second chair stand. Well, so I'm gonna do that later. And then it says, okay, I'm at challenge level 5. Remember, I chose 5. Would you like to increase your challenge level? Okay, I will. Yes. Here we go. Now I got it. We increase the challenge level next time. So you could see how that's one activity and how I've kind of gone through the flow of selecting the activity. This is, by the way, the clinical interface. So LudoFit has LudoFit for clinicians. This is something that you guys could use in your clinical sessions. You could load this up onto your laptops, onto your iPads. It uses the web camera for motion sensing, and we are giving this program for free. The LudoFit Pro is at no cost for therapists to use during their practice, and the goal is to give you guys a tool that you can really use to spice up your therapy sessions, engage your patients, provide that cueing that you can help. And I would love for you guys to join. And we'll talk a little bit about how you can get patients on if they're interested to use this on their own. So we'll talk a little bit about that. So I'm going to go ahead and I'm going to show maybe 2 more exercises. So let's do the rafting and chilling. This is another one here. I'll click on this activity. This time I'll do it in seated position. So I'm going to click over here. I'm going to put again, say level 5, and I'll start. Okay, so this, like we talked about, could be for individuals wheelchair bound, seated position. This game takes you to the Petrohue River in southern Chile.
This game focuses on upper
Okay, so I'm
body.
going to skip the tutorial video for you guys. It's asked me to stand up, but actually I'm doing seated now. So I'm going to actually
Please align your body with the
make sure I'm
silhouette
doing
on the
this
screen.
in seated
Please move
position
back.
here. Okay, here we go. So here I am, and basically what I'm doing, I'm reaching my arm to reach for these objects on the screen. So I've got 2 hands there, so I basically have to align my hands with these objects on the screen. See where these hands are, I'm kind of reaching for these hands, and this I'm doing bilateral, so what I'm doing is just focusing on arm movements, and you can see that volcano in the background a little bit. Got to grab that fishy. Don't forget about the fishy. Here we go. Oh, I see another fishy. It's about to come up. Oh, I think I missed that fishy. And here we go. This is 2 hands. This is bilateral movement. And we're gonna grab that apple off that tree. Here we go. All right, having a great time. And we have different environments. So this is the Petrohue River, like I mentioned, in southern Chile. We have another environment that takes you to Costa Rica. I don't know if anyone in the crowd has been to Costa Rica, but there's some beautiful whitewater rafting there, and we created an environment for that. Here I go, using both hands. Okay, so there's a lot I'm doing, and like I said, the game gets more or less difficult based on your level of effort that you can you input. Okay, so here we go. I'm going to pause on that one and finish the activity.
Click on the number that
Again, it was, there we go. Let's say I rate it a bit
Got
hard.
it.
It'll ask you, do you want to decrease the challenge level? Sure. Okay, I'm going to go down to level 4. So a lot of people, they really track that. They're like, okay, where am I at? Where do I want to get to? And you could see these progress bars, coming up and progressing over the game. And I'm going to show, before I show 1 or 2 more, if I have time, I want to show you about the question about inviting clients. So I really want to stress that this is a program that is free for clinicians, okay? you can use this program, you can download this program, and we're going to send you the information. I'll put it in the chat and everything. You can get on this program. We can give you tutorials on how to use it. There's a quick start guide. For a patient, you can click on invite clients. So that's just the email address I have for them there. So basically, let's say you're with, Gary, and Gary's using this program, and you say, you know what, would you like to use this at home? And Gary says, oh yeah, I would. That would be amazing if I can use this at home. So you can put in Gary's email address, and then you put it in, and I won't do that, but you can get the idea. You can have him send an invitation. You can decide, okay, standing or seated. You can always change that if he wants to. You can put standing or seated. You can decide, well, is the initial 30 seconds sit to stand assessment required? And then how often should the assessment be performed? How often? And you can actually track their progress remotely. And then you can send them that invitation. And then they're going to get an email with that. And I'm going to go ahead and, well, I won't show it now because, but they'll get an email saying, hey, you've been invited by your clinician's name to join LudoFit. Now, how does it work for the patient? The patient gets a 30-day free trial. For most patients who come on board through this program, they get the cost is $15 a month. However, if you join as a clinician and you start inviting patients, you'll be able to send patients promo codes so they can only get on for $10 a month. So they get a 30% discount as a clinician to invite patients. So we really want to make this a win-win-win-win-win-win-win-win-win for everybody. Patients, loved ones, clinicians, health systems, and all. So you guys get this program for free. There's a whole suite of games that you have. You can invite patients. They can try this out. And if they want, they get a really nice discount to get on board. And then we can continue developing new games. That's always a good thing. I'm going to show a dual tasking exercise. So you can get a sense of that, and then we'll maybe pause for some questions, and then go from there. So I'll go ahead and click on Explore the Temple, which, like I told you, I spoke with one of our I'm going to also do this one in seated position. I spoke with one of our clients yesterday. I was doing some research, user research work, which we're always doing. And I asked, and she really told me that this one and the cycling the Tour de France was her favorite one. So that was really fun to hear. I'm going to just put the duration. I'll put it at 3 minutes, but I'll probably do it less and go into the game. All right, so we're getting started on this program, and here we are. So you may notice,
This game is a
pause on
Please move back.
so you may notice the environment. This is an Egypt environment that we're taking to. This was actually one of our users, earlier users, had the idea of doing something related to Indiana Jones. His name is Paul Chorney. He's actually 91 years old, and now he's 91. Still using the program, been using it for years. One of our first users, still using it pretty regularly and giving us feedback. And he is the one who told us to do a game Indiana Jones style. So little shout out to Paul
Please
Chorney
move
from
towards the
Arizona.
center.
And with that in mind,
Please
I'm
move
going to go
back.
ahead and go back here. And I'm going to do this in seated.
Great. Now hold still.
Okay, so I'm going to sort of walk you through or talk you through the game. I'm not going to be able, because I'm skipping the tutorial video, but here we are. So now I'm basically doing, oh, actually, just a second here. I want to make sure that I think this was in, I think I did this in standing position and not seated. So I'm going to make sure that it's seated so you guys get to see that. Okay. Yeah. Okay. Because the seated game is
This
different.
game is a
You're not just
Please
doing.
move towards the center.
Okay, stay seated. Okay, that's
Great.
the pro.
Stay
Standing position,
seated.
not seated. Okay, here we are. So this is a trunk control activity, postural control, and I'm basically navigating. Oh, now I got to move around. So I'm navigating around the changing environment. Okay, navigate around the artifacts. Go get that star, and I got to watch.
Look out for the
Look
symbols.
out for the symbols. All right, so you see the little Turkish coffee there. Watch out for that Turkish coffee, because And I gotta remember that. And I continue my physical exercise. I'm doing core strength. I just saw a symbol, the Turkish coffee symbol, and I gotta continue. And oh, what do I see there? I see another symbol. That looks like a little pharaoh. Okay, so I saw Turkish coffee. Then I saw a pharaoh, and I continue along my way. So I'm doing multiple things at the same time. I'm focusing on the movements related to, getting through this path, but I'm also focused on remembering things. So what did I see so far? Turkish coffee and pharaoh. So don't forget. And then we have another symbol coming up. So those look like flowers or broomsticks. And we'll see. So I continue along my way. So what did I see so far? I saw Turkish coffee, I saw a pharaoh, I saw those broomsticks. And now it's, okay, here we go. So
Select the first symbol you observe.
Select the first symbol you observe.
Lift
Okay,
your
so you
arms
get
to
the
the
idea.
side to select
So
your
it means
answer.
something. It's not just remembering it for no reason. Now I have to answer the quiz. What did I see first? Well, let me do maybe a wrong answer to start. No, that's not the right answer. I got 2 more tries. I'm pretty sure it's the Turkish coffee. All right, let's go. Puzzle solved. And it's going to get more and more difficult as you go, but this was a little bit of a warm-up and I continue along my way. So that's a key piece around navigating the changing environment, focusing on. So this is a highly cognitive-oriented exercise. It's a physical exercise, and it's supported by the clinical evidence. It was actually developed in
Click
collaboration.
on the number that corresponds
All
to
our
your level of
games, I should
exertion.
mention,
Got it.
are all our games are developed. We actually had key partners for each of our activities. This one was developed by a really well-respected brain health coach and trainer named Ryan Glatt out of the Pacific Brain Health Institute, who helped us develop this game and really educated our entire team on the theory of dual tasking and what we really want to work on creating. The key theory behind it is called spaced retrieval therapy. It's when you see something, you notice something, and then you are being asked to recall it, a minute later, 30 seconds later, and it could be more how many things. There are different ways of grading this exercise that are programmed into the game. What's the length of time in between when you saw the object to when you're being asked to recall the object? How many objects do you have to see and are you asked to recall? And there's other elements in terms of the challenge level of the quiz itself. So that's the key element. And I want to show one last thing. So basically, we talked a little bit about inviting the clients very easily. They get the invitation. We also have informational cards that you can give. So what I'm going to do, I'm going to go back to stop the share and then share my own back to my presentation. So I'll go ahead and do that. All right, so you see my presentation now. Okay, great. So it's free. Now I put free for 12 months, but actually this is free. We're looking right now, we're focusing on extending this free offer for clinicians. And we think that this model is a great model. It's working really well, and why not keep it free for clinicians? So you guys can get started. I'm going to put the information in the chat in a few minutes when I'm done, and then you can use this program. There's a way where you can on our website to ask for informational cards, so we can send informational cards to you, and then you can give it to patients. There's also one other thing I do want to show that's a really important piece about this. So I'm going to head and do that. But I have to share my screen again. Okay, bear with me. Here we go. All right. So what you're seeing now is the website. So as a clinician, you guys are going to be able to go to the website and actually click on any patient's name and then see exactly what they've been doing on all the different exercises in terms of time of play, in terms of rate of perceived exertion every day. This is actually a real patient, but you don't see their name. You just see the stats here that I want to kind of show. New Zealand game, rafting in Chile. So time of play, he did it for 5 minutes. He was at level 2. He got 61% of the reaches. His rate of perceived exertion was 3. He got stars. So that's basically the number of movements he did. The rock climb, ski the Alps. Seems like this person's doing it every session. They're skiing the Alps, and they're at level 2 regularly. They're rating it at perceived exertion 3, but it seems like they're intentionally keeping the level as it is. So maybe this person likes that it's it's 3 actually is just right. Right, I forgot. 1 to 5. So yeah, 3 is just right challenge. So they're staying at level 2. So that's really important information. And as a therapist, you can really and then you got the explore the tempo piece, and here it's telling you how much sidestepping. So there's a lot of data that you have. You could print a report, you can export it in different ways. So add it in your notes. There's ways to document this activities, these programs in terms of neuromuscular re-education, therapeutic activities, therapeutic exercises. So there's a lot to cover, but I see that I want to save some time for questions. So I will yield the floor. Who any questions that you have, I'm happy to answer them.
Yes, yes. That's amazing. First of all, Mark, that's really good. I really enjoy. While you're doing the standing, I'm doing the sitting part.
I noticed that. Yeah, that's great.
Yeah. So here I have some questions here already. What I think Kurt, this is part of this, right? What are the differences seen in brain activity for full versus semi-immersion, like the virtual reality? It seems that depending on the type of full immersion, that it could be much more passive experience and potentially will be less beneficial. So
if I understand in terms of the full immersion being less beneficial or more beneficial, or just want to make sure I'm understanding the question.
he's just want to know the benefit, the difference between semi and full immersion, because he's thinking that when it is less, if it is more passive experience, it might be less beneficial. He's just asking.
Right. Yeah. So actually, what we found is that the level of brain activity and engagement is actually comparable between the two. So when we're kind of defining what are all the parameters, we're looking the risks and the benefits. When you're in front of a screen, you ever notice when you're on a train of thought and you almost forget where you are? You don't need to have a virtual reality headset to be fully immersed in a conversation, in a game, in anything that's like that. And one thing when we found it, even if it's a small iPad screen that you're looking at, you're there, you're fully
Yes.
there. You forget where you're at, but physiologically, your body is much more aware of where you are in the space. So that it provides a very comparable level of immersion, but much more benefits in the safety piece, especially for people who are, older adults who are interested in using something like this at home.
Yeah, good point for the safety part. Yes, thank you. And how about what are the risks for those who have vestibular problems? Is the immersion still advisable? Thanks, Mr. Evan. That's from Max.
Yeah, so every patient is unique, as we know, and I think that that has to be a decision. That's an important decision to make by the therapist if this is something that's appropriate. You can always start at seated position. You can invite a patient and give them a lower risk experience. So the exercises they're doing are more arm based. They could be sitting in a chair with arm rests. So that would be a start, and that allows the patient to get accustomed with the experience of moving and seeing their movement reflected on the screen and so forth. So we do have a number of individuals with vestibular dysfunction on the program, using it in unique ways, and always starting slow, starting easy, and then slowly moving their way up as their brain starts to get comfortable with using play and game in this type of environment.
Wonderful. Yes, and how about Miss Sue asked, does the Ludofit have any semi-immersive games for wheelchair? We have that already. I think the next question of Sue is about how easy it can be installed on a TV. I know this is more on Apple products, right? But how about what the
Yeah,
Apple
so
products,
yeah,
but how about TV? Can we
so it's
put
a
it
good
on the big screen?
question. This can be used. You can, so in a clinical environment, we often have therapists download this program on their laptops
Mhm.
and plugging the laptop into the TV.
Okay.
And then getting it on the big screen, you really get that immersive, that big screen feeling, and the high tech feeling. If you for your clinic to really kind of up it, and we know that because we've had a lot of experience with our Gentronics program, which has a TV. So being able to do that, it works on Windows devices or Mac devices. So Mac laptop or iPad, you can use the Air port, I think, on Mac to beam it to the TV. So that's one way to do it. And often they have the TV there and the laptop in front with the web camera sort of doing the motion sensing.
Yes, I use it on my Windows. I don't have the Mac. Yeah, and that's really good. Another one. This is a little bit challenging questions because he's very competitive. How about, does the Ludo Fit have a kind of competitiveness feature? Let's say one is going to or two users competing with each others, sharing what's the best scores, things like that. And do you think it will help a lot with the user's adherence to the exercise?
That's a great question, and actually we're working on that.
That's a good
Right
one.
now, you're competing against yourself. So actually,
Okay.
when we do this when we do our research, there's different types of individuals. There are people who are more explorers. There are people who like more play. There are people who are more competitive minded. So right now, the first thing we put in there is really competing on your own to your own personal best. But absolutely, that's one of our key important pieces of our product roadmap. Is we're going to be integrating so people could pair up with friends in groups and then have a little pool of people and can compete amongst each other. We have this program in a number of senior communities where they're starting to do that. So it's not fully in the way that we want it to be, in a very usable way. Or easy to use way, but that's definitely on the future, in the near future for this program, is incorporating people to pair up with friends and start to compete in small groups in a friendly way.
Yes, yes. We have only 3 minutes, guys. So we have just put here not your questions, but I will put the question here of Marie. She asked, what is the gate norm if it's a required prior to Ludofit?
Well, we do have certain certain clinical elements that serve as advisory pieces that I'm happy to share in terms of ability to stand or seated. Right now, we've expanded this program so it could be used with pretty lower functioning individuals in seated position. So it's not their a full and active and unsupported gait is not a required part of this program. You could be doing this in seated position. In fact, we have this program being used in hospitals for individuals who are bedbound. So they're in their bed in dialysis units, and they're doing some of the movements, the upper body exercises, just in their bed to start to stimulate physical activity. So we really did a lot of effort to make this program widely applicable to individuals of different levels of function.
Wonderful. Thank you so much. So Net asked question here, but you can answer it also in the chat if it's longer. She just want to ask the limit gauge of the difficulty of the activity. Will it assess if the activity is hard to the patient related to cortisol release? So more on
So, Jen,
level.
can I butt in? So you talk a lot about the cortisol. So we know that the cortisol is a stress hormone. So will the app itself will assess if the activity is way too hard for the patient, because we want it to be on the level only of play and relaxation. So what will that give like a grade for the patient if it's too hard for them?
Absolutely. So we actually the program actually assesses the patient in the game in real time and also asks the patient about their level of effort. But the idea is like you don't want too much stress or excitement, but you don't want too little either. You really want to get to that
Yes.
just right challenge. And we really tried hard with that to help the patient in different ways, whether they start at the beginning, whether they do the assessment, or whether through the clinician helps and sets the right level for the patient before they start using this independently. So
Okay. Yeah.
very
Thank
important.
you.
You're welcome.
All right. Thank you so much. We're still on time. Thank you so much, Dr. Mark. So we appreciate you live from Canada. So thank you. And
Thank
we
you.
learned a
Thank
lot
you.
from you. And we appreciate your passion to share this for us clinicians for free and giving very affordable for our patients as well. Definitely, this is the things that we would love to apply soon. Maybe not only Monday, maybe tomorrow or tonight. Okay. Thank you, guys.
Thank
And
you.
thank you
Thank
so
you.
much, Mark. We
Thank
appreciate it.
you.
All
Thank you.
right.
You're welcome.
So I
Thanks,
would love
everybody.
to share this. Okay. And we have, so that's our Mark. We really appreciate you sharing your knowledge to us, and we have your certificate of appreciation. So as a co-founder and CEO of Ludofit, thank you for sharing your knowledge and expertise here in our Geriatric Rehab Summit 2024, given today 16 for the fifth annual event. All right. Thank
Thank
you.
you.
And we appreciate you.
Thank you.
Yes, and guys, majority of you, Ludofit is one of our gold sponsors, and we learned a lot from this presentation. What is it? We will put on the chat how we can trial as well and make our assessment or like our therapy fun and enjoyable for our clinicians and definitely for our patients as well. All right. Thank you again for your brain,
Thank you.
Mark. And also just write also to credit the brain of the innovator and the designer of the play as well. Thank you.
Okay, will do. Thank you.
Thank you. You're welcome. You're welcome. Okay, guys, going on to our next speaker. These are all very innovative and fun. How about making sense of the sensory systems in Parkinson's disease? So the previous one, we can apply any cases, any kinds of neurological, musculoskeletal. The pop doc, we focus more on orthopedic, manual therapy, joints prevention. But how about more on neurological with Parkinson's disease? What are the things that we can do for that management? We have Dr. Erica DeMarch to discuss about that. She is the founder and CEO of Step Connect, and we will learn more about that with her tonight. So Step and Connect is dedicated to improving balance and reducing falls with innovative devices and educational programs. Her Balance Matter systems developed by our founder, which is Dr. Erica DeMarch. She's a physical therapist, over 20 years of clinical expertise. It offers a fun, functional, and science-backed approach to training balance. So they have a portable and affordable devices. So these are more on sensory feedback. It's a modal training to maximize motor learning performance. So now, people effectively find the just right balance exercise, those to improve their balance and movement. So let's learn more about the making sense of the sensory systems in Parkinson's disease. And also, Dr. Erica DeMarch made a book, and the children's book also in what you call this, inspired by her daughters as well. All right, Dr. Erica, I'm giving you the floor. Thank you so much. And here it is. Are you here? Let me see. I need to find you. But you are already a co-host and you can share your screen. Thank you.
Okay.
See. All right.
So, you know what? Let's stop that share for a minute.
Yes.
But it's
Mm-hmm.
1
Yes,
second.
we can hear you. Thank you.
Can hear me? All
Welcome,
right.
Dr. Erica. Yes,
Thank
yes.
you so much for having me. I'm gonna just pull up the screen for a moment.
Mm-hmm.
The wrong one pulled up. Let's see.
And I believe Dr. Erica is it in Colorado?
Yes, I'm in Denver right now. Is anybody else in Denver? You can put it in the chat box. Let's see if I can just get
Denver. Mm-hmm.
All right. Can everyone see the first screen then?
Yes.
Looks good. All right. So today, and thanks, Mark, for your presentation. I'm gonna, based on hearing his presentation, I'm gonna give some tips now on the sensory system. So watching him weight shift and watching you doing your weight shifts, how do we cue the sensory system? So if we're looking at the visual system or the somatosensory system or the vestibular system, if someone's doing this kind of motion with their head, do we want that or do we want a head writing? So we're gonna look a little bit more on some of the tools that we might be using, but being able to cue that for our patients. So as much as this is just for Parkinson's that I'm gonna be stressing today, you can apply some of these concepts to your other clients. So really today, I'm hoping that your observation skills, maybe you learn something different on when you're looking at a client. And then I'm really into integrating whatever you're doing in the sensory systems. So we'll be talking about that. But one thing I thought as we started, and it's up to everyone, right now I only see a few screens, but we've been sitting for a while, it's a Friday night, right? So does anybody, or can you let me know, I can try to put the chat here, would everybody like to exercise and get up a little bit to move? So that's one thing I was thinking to get us all going. So anybody's welcome to take their cameras off so then I can actually see everyone moving. So I'm gonna stand up, and before we start, it might help you throughout the presentation to kind of feel your body. Because how much of our clients, we're telling them to feel, but how do we feel our bodies? Okay, so when I think of balance, I think of the 3 parts of the balance exercise: attaining a position, maintaining, and recovery. A lot of our clients only think of the maintain, right? They're like, I'm just gonna put my finger here to get into the position. Okay, I'm here. But getting into the position is just as important. So I'm gonna see, let's see, when I shared it, I might have to stop the share for a moment because I'm gonna put on some music and I think I have to change that off. Is that okay? And then I'm gonna share it again. All right, so I'm gonna stop the share, put some music on. So I want you to think of how you're feeling right now, both figuratively, like what your mood is, what your energy level is, and then also what you're feeling in your feet. All right, so we're gonna do a little bit of exercise and we're gonna put a song on called Feeling Good. So let me know if you can hear it. Can you start hearing the music? All right, so push down through the floor and reach up. And then back down. Again, push down through the floor to get taller. You know how I feel. All right, hands on your ribs and slide your fingers down your leg. You should feel your rib cage open and then come back down. Slide your hand on your other ribs and let your head drop. It's a new day. One more time. It's a new life. Feel it opening. Slide a little lower. And again, slide your hand down. Excellent. Hand on your chest now. Rotate to 2 and 10 o'clock. Back and forth. Feel that rotation. Your head should be vertical. All right, we're gonna go into hamstring stretch. Stand in a staggered stance. Hands in front of your hips. Push your hips back and feel it crease. Hands now on your butt. Push forward. Press down. Feel that weight through your foot. Again, push back. Put your hands on your butt, come forward, push down. Let's do the other side. I'll go back a little bit. Push back, toes up, feel the stretch down here. Hips forward and down. One more. Back. Hands behind your butt, push forward, hips down. I'm gonna stop the music for a minute. And I want you to feel a lot of, don't know where our hips are, right? I don't know if that helped you gain awareness. I'm always trying to get my patients' hips forward. Having them feel what you want is going to increase some of that motion. So we're going to do one other exercise. I want everyone to stand on one foot. So I want everyone, so before you stand on one foot now, what was your starting alignment? Were your feet together? Were your feet apart? All right, so that makes a difference. I know our standardized test does not have that. One day I'm hoping it will. But right now, if you can see, I'm on a mat, and I want everyone to find their Goldilocks zone, similar to what Mark was just talking about. Here's my normal stance. I'm going to shift and stand on one foot. This is the attaining or transition motion. Now I want you to stand and shift a little bigger, or a little bigger. How far can you stand on one foot and then stabilize? So this is attaining a position, moving your center of mass, right? But this is only in one plane. So let's play around now one more time, go into a warrior stance. So right now I'm in a warrior stance here. How can you stand on one foot here? Now I have to turn and stand on one foot. Turn and stand on one foot. Maybe I'll take a bigger step to stand on one foot, or I'll take a smaller step. So looking at how you control your center of mass. So that would be looking at transition or attaining a position versus maintaining. And I use a lot of sensory feedback. This morning I was treating a client and had her on textured foot pads to feel the ground. So I want you to picture the triangle under your feet, push down and close your eyes. Feel your feet, right? But then what is your head doing? So we're going to talk about, and we're going to get you guys up again to see what is your head doing different positions, what is your feet. If you lose your balance, do you step? What happens for that? So let's get back, although I did almost do the whole song, but then we wouldn't have time. So everyone could sit back down if you were standing, and then we'll go back to learning about the sensory systems. All right. So we're going to talk a little bit more about recovery also. Let's see. There we go. All right. So for Parkinson's, this is super important to look at balance. Unfortunately, 68% of people with Parkinson's in the community fall at least one a year, which is 2 times the fall rate in older adults. And then recurrent falls is even more of an issue, right? And talking just about self-efficacy, the fear of falling, all of that increases. One thing that we're going to talk about is the sensory systems, and they are underreported in this population, but can have significant impacts. So that's something we're going to talk about and something I'm very passionate about. So predictors of falls: falling in the past year, freezing of gait, self-selected gait speed less than 1.1 meters. If you're here in America, you can convert it to 3.6 feet per second or 2.4 miles per hour. I think it's important to talk to your clients, especially if they're on the treadmill. And then slow backward gait has been coming more and more in the literature, looking at fall risk, especially for the early stages. So Mark talked a little bit about self-efficacy, and I think this is really important for anybody when you're starting to talk about balance and falls. So if somebody has mastery of experiences, these are the 4 sources of self-efficacy. And if somebody, how many times do you have a client that are like, I don't have good balance, Erica. I'm not good at balance. I never was. They don't have that self-efficacy. Were they trying something out of their limit? So we need to give them those positive experiences. So I usually set somebody up to succeed and then clap, cheer them on. Wow, you did so great. Now we have to make it harder for you. We're wasting your time, right? Now we want to keep adding those layers. So mastery of experience is super important how we set somebody up. Social modeling, if you're in a class setting or see somebody else in the gym, if they see somebody else, their peers, doing something that they want to do, it does help. All right, so I think especially in group settings, it is really helpful. And social persuasion. So if I'm, like I said, that cheerleader, but I love butting up people or butting up a husband or wife or grandchild, whatever it is, to try to motivate that person what they're doing. Last is your interpretation of physiological and emotional responses. It's our job to tell them what to expect. The balance is very complex. It's not orthopedic that we see a straight linear progression of people getting better, right? Sometimes there's other variables, sleep, things like that, that some days we're going to have bad days, some days good days, but overall from here to here, we will get better. And that is very important to talk to your clients about. So I don't know how many people have seen this article. It's a little older now, but I think it's really well done. I'm hoping that there's a follow-up in the future on this article, but it's the 4 domains of self-efficacy. So this is for older adults, but I talk to all my clients with Parkinson's about this. I had 2 ladies who told me that they wanted a dual session together. They were friends for balance training, and they both had totally different goals. So one of them was afraid that if she almost fell, she wouldn't be able to recover. So if her foot caught, versus another, the other lady was afraid that she can't get up from the ground. So totally 2 different goals. So this is, I show this picture and I say, you know, what is it, pre-fall that you're afraid you're gonna fall? Is it near fall that you can't catch yourself? The landing of falling, or the completed fall? So this is a really nice way to kind of guide your session, because your sessions, your training is going to be completely different based on what they want to work on, right? Or what they're worried about, or their confidence level. So I don't know if everyone's familiar with some of Gabrielle Wolf's research. I love a lot of her research. In this article, I talk to my clients about. I think it's super important. We are setting our clients up before we're even giving them an exercise, right? So basically this study told one single statement was only provided. Active people like you with your experience usually do very well on this task, versus somebody not getting anything and having them just do it. That one sentence alone, that person retained learning, balanced longer, and had higher self-efficacy on the delayed test of learning. I think that's pretty powerful. So I think the first thing before you're even with a client, especially somebody with Parkinson's, is tell them that they're going to do well on this. You're going to keep, this is something that, you know what, and if they don't, hey, you're going to get better at this. We just have to practice. Really, really important. So I think the minute you're with your client and starting to talk, think about that before you're even doing any of your balance training. So lately I have a lot of clients who, when I ask them what they're thinking about, they think about, oh, I'm hoping I don't shuffle. My wife always tells me I shuffle. Oh, I'm thinking of, I hope I don't fall. Or think of all those negative words that are already in your mind. We just saw the Olympics. Do you think any of the Olympians before they go on are thinking of some kind of negative, I hope I don't miss that landing, right? Or I hope I, so for balance, for some reason, and I use an experiment, I tell this a lot of my other lectures and tell therapists, ask your patients what they're thinking about. Some will say nothing. Some will like say, I hope I don't fall, but it will really tell you what their mindset is before the exercise. So I took this image for a patient last week. He loves the Beatles, and his wife kept saying every time before he walked, he was hoping he didn't shuffle or bend forward. He had this Parkinson look that in his mind. So I was like, what do you want to look like? What do you want to feel like? And this was the look, like, right? Look at that, like nice posture. I guess, I don't know, is that George at the end? Like the head posture could be a little bit straighter, right? But if like we want these long strides, we want the heel strike, like, and you see how long, you know, pretty nice extension of the trunk. So ask your clients what they want to feel like, what they want to look like, because, and model it for them. So there's a lot of research. I didn't put all the articles on modeling. So you're showing them the exercise and mental imagery. And I think we need to do that in rehab just as we are doing in sports already. So questions, the CDC asks these questions. Have you fallen in the past year? Do you feel unsteady when you're standing or walking, or do you worry about falling? I don't think these questions are enough for us as clinicians. It's a screen. So we need to elaborate. So more questions. When and where do you worry about or fear you're going to fall? So when, I just started putting a few questions, but there's so many questions for when. So for Parkinson's, right? What time of the day? Maybe it's more in the morning. Maybe it's later in the afternoon. Is it connected to your medication cycle? Are you wearing off? Are you ready for your next dose? Does fatigue play a role in when you feel unsteady? That's even with people without Parkinson's. Is there sorry. Is there a correlation between pain levels? What about what activity are you doing? Is it from getting out of a chair? Is it getting out of a chair in front of a table versus getting out of a chair from the toilet or getting out of the toilet, right? So many different things you're going to be talking about when. What is your anxiety? Is it mood? I lived in New York City before Denver. I had one client with Parkinson's who told me the only time was crossing the street, like, right, the avenues are different than the streets, and if he had to cross an avenue, his anxiety made him freeze. So we worked on strategies for that, but other times he didn't have that freezing. I have another client I saw this morning who told me certain shoes she feels off balance, and then we had to evaluate her different shoe wear. What about the dark? Is it the dark in a movie theater, you have to go to the bathroom, or is it dark at night, you don't put a light on, you don't want to wake up your spouse? Inclines, ramps, and slopes, we're going to talk about this more for the vestibular system, but really important. Think about just going to a baseball game, or if you're going to different, here in Colorado, hiking, right? What happens when you're going down that hill? Are you following the ground? Are you referencing gravity? We're going to talk about that more. Transitioning from one surface to another. I still remember one client who told me he would not go to his daughter's house because they had a really plush rug, and from switching from the plush rug to the floor really bothered him. And then we're going to talk about the speed of transition is actually even more important for people with Parkinson's. Walking, standing in crowds. I love watching everybody at the airport, right? When you're at the airport watching everybody's movements, the stop and go, is that bothering people? Or is it, hey, if somebody bumps into me, I'm not going to recover? All these questions are going to help you know what type of balance work you're going to be working on. Small spaces, we know that could be something for freezing. Is it small spaces in a bathroom? Closets? Always, I have so many clients who tell me the closets are where they have some falls because it's reaching in a small space, things like that. So more questions to ask. If you have a client, just a few of these little questions, then they might start talking. The interview is so important for balance. So I love this quote, and it's, I think, perfect for this conference right now. In order for us to truly create and contribute to the world, we have to be able to connect countless dots, to cross-pollinate ideas from a wealth of disciplines, to combine and recombine these pieces and build new castles. I think balance is complex. That middle person in this picture is your patient. All of us as a team, we're going to change our size depending on different things, but we really need to work as a team. Today I was on the phone trying to figure out cardiology from a patient who, that was he doesn't want to walk now because he's afraid of his cardiac issues. And then now his Parkinson's is progression. So how do we work together as a team and learn from each other? So we do need the entire team. I wish balance was more simple, but somebody can have great balance and still be falling. Is it a medication? Maybe they're orthostatic. There's so many other aspects of it. So we are talking today more about the sensory systems, but I don't want to kind of put down some of the other pieces that are still important. But for an hour lecture, we're not going to talk about each of these, but know that all of this is important. So we're really going to be talking about the integration of the sensory systems, how the vision, our eyes, our vestibular system, our inner ear, and then our proprioception from our joints, our skin, our tissues, integrate into our brain. So right from our brainstem to our cerebellum to give us this motor command and sensory commands to actually get coordinated movement. So I don't know how many, I love reading all about the motor control theories and different theories. I love the task-oriented approach. All right, so this really looks at context, and I talk to my clients a lot about context because sometimes the individual doesn't need to change, right? We're always trying to change the individual, but sometimes it could be the environment that needs to change, or sometimes the task. So other times we are working on the individual, but I think all three need to be looked upon. So I was just in the mountains actually with a client this weekend, and she couldn't get out of her bed. She has Parkinson's, and she would get frozen and couldn't get out of the bed. So how do we change that? She's like, I don't always want to ask my husband to sit up when I want to eat or sit just for a little bit. So we put tape on the floor. So we changed the environment. I didn't change her ability as much, right? Because she still had the same strength, but I wanted to get her to perform right away. So I put 2 pieces of tape right on the floor. So watching her task analysis, Her eyes were going a different way, so we're going to talk about vision. Your eyes should lead the motion. So I wanted her eyes to look at the tape so she knew which way she was rolling. I wish I had this on video because it was really cool to watch her all of a sudden get it. But her feet, as she would stop, right? For Parkinson's, sometimes we don't have a smooth movement. We stop in the middle of a movement. So her feet would think about rolling at the edge of the bed. She would like just stop and then she would get stuck. So for her to know where that motor plan of knowing where her feet go to those two lines, she was able to get up by herself. So sometimes just changing that one task is important to be able to, the task is still getting out, but changing the environment to cue her a little bit. And we'll talk more about that. So postural control. Faye Harrick, if you read some of her research, really, the mini best test we'll be talking about, looks at all the resources for postural control. So this is how I kind of look and discuss this with my patients. First, really, honestly, biomechanical and your posture makes a big difference. And we're going to stand up again to see that. What is your movement strategies, reactive versus voluntary balance, your sensory strategies, orientation in space, control of dynamics, and cognitive processing. So all of these are important to be part of the picture of what we're going to be assessing and training. So I thought this study was important because I am going to be talking more about the sensory systems, but I want you to realize that the sensory systems are important to address. But if you're doing the sensory organization test, and if you're not familiar with that, I can elaborate. But if you're looking to see, if somebody can stand on foam, eyes closed, what happens to each of that? When you just did SOT, 24% had abnormal balance and 76 normal, versus if you're looking at the mini best test, you actually 71% actually had an abnormal balance. So sometimes it's not the sensory organization part. It could be the reactive balance. It could be another aspect that you might not be missing. So again, I'm going to be talking about the sensory systems, and that is important, but it also could be other aspects. So your visual system, right, helps us know where we are in space. We orient ourselves to our surroundings. We're able to see edges, obstacles, curves, and be able to know what we need to anticipate to be able to do next. Versus our somatosensory system, that's in our joints, right? If you take your fingers, close your eyes, can you touch your fingers to one part? I use my eyes to be able to see that motion. Can you do that with your eyes closed, or do you miss? Do you know where you are in space? Where our inner ear references gravity, right? It orients us. If I was sitting on a rock, I wouldn't be here. My eyes and my head would orient to vertical so I can see. So that your gaze stabilization works with where your head is in space. So we use different systems based on different environments, right? So in a well-lit area, that is firm ground, we are mostly using our somatosensory system, we're feeling, but we're also using our vision and our inner ear. All of a sudden it's dark, we can't use our vision anymore. We're going to use our sense of touch even more and our inner ear. Versus now we're on inclines, rocky ground. The ground is not giving us the right reference. We're going to use mostly our eyes and then our inner ear. So this is a great time to talk to your clients about that, because sometimes when they say, why are you making me close my eyes? I never close my eyes. It's because I'm up training those systems. So when you're in different environments, we can use that system when we have to rely on it. So visual disorders. This is something I worked in a brain injury unit in the beginning of my career, and I really learned a lot about how the eyes can be affected and how many people don't actually talk to you about it. Same with a vestibular clinic. This can really reduce and be disabling for your activities. I learned this myself. I was in a car accident a while ago, and when I had a whiplash, that changed how I used my eyes, and I had to retrain that to get back to 100%. So you start seeing how fast can your eyes move is going to make a difference depending on your environment, looking at all that visual part. 80% of people with Parkinson's who fell within 1 year had some visual impairments. All right, so compared to non-fallers. Difficulty reading, double vision, misjudging objects and distances are some of the common symptoms that people might complain about. I think it's also really important. I feel a lot of times some of my clients, I'm the first that they will discuss this with, is visual hallucinations. So if that is, and that can be also disabling for their caregiver for some of the things they're seeing. So I think this is something that you can bring up and have them feel comfortable to talk to you about. Are you seeing anything else that you don't, or asking their caregivers if they have any visual hallucinations, so you can talk to their doctor about it. So some of these visual disorders are due to Parkinson's or more essentially driven, but some could be side effects of their medications or some surgeries such as DBS. So we're not going to go into full of this, and let me know I can, but I'm going to kind of move to kind of give you a glimpse of all of it. But of course, if we're here longer, we can go into each part. But visual acuity can be affected, your color vision. We're going to talk a little bit about eye movement problems, because that's something that we can assess a little bit, looking at smooth pursuits, saccades, and convergence. Your visual processing, right? It could be more central oriented, your peripheral vision, object perception, visual spatial construction, and motion perception. And lastly, looking at spatial neglect. So similar to somebody who might have had a stroke, patients with left-sided Parkinson's disease actually do perceive objects within their left visual field smaller than the right. So if you have somebody who keeps bumping into something in the left, is it because they actually don't have that? So I work a lot with a neurooptometrist, and I've learned a lot from him. I have a podcast that I interviewed him on saccades. There's so much to learn in the visual system, but I think it's our job to also look at how that affects their everyday life, especially when they're turning, right, or going around or circumventing around an object. So saccades is different. That's when our eyes jump from one target to another, right? So saccades really help us. I only thought of voluntary saccades until I interviewed this neurooptometrist. There's 7 different saccades. So there's memory saccades, reflexive saccades. There's all these different ones that we're not going to go into a whole lecture on saccades, but it's super important to know how your eyes can jump from one target to another. With Parkinson's, they decrease just like bradykinesia. They're going to have smaller size, so they're going to be smaller in the saccade. So maybe they didn't jump and see the entire room because their eyes only jumped here versus I saw everything over here. Or if your head is down in this posture, where's your visual system? Where's your gaze to be able to see that room, to anticipate, to be able to know how you're going to be moving? Different is when they're turning, they have lots of little saccades, right? Because now they have that in block turn. Versus, so really, I use a lot of laser lights, and I'll give you some tips of what I do to help people's eyes move a little bit more, to move them bigger, to move them faster, just like you would train a muscle, you can train their eyes. So greater awareness of your visual observation during gait. So if you can scan the environment more, you're going to have improved safety, right? If you are only targeting this small area, you're going to have a higher fall risk. Because how many times you see a client that they're like, I didn't even see that. That's why I fell over it, right? And it's because their eyes didn't move around the room. So if that client says, hey, I joke around, my mom and dad, I test their balance all the time. My dad has better balance than my mom, but my dad does not look around. He doesn't scan. So if you moved anything in the house without telling him, he will trip over it. So I think, you have to kind of know, how do you train that to kind of improve that person's awareness? So you can use, I use painter's tape a lot during my sessions, and to help people increase their awareness. So you can put painter's tape at the middle of a chair to help somebody, that's that person who thinks they're in the middle and they're sitting like this in the chair, and you're like, nope, you're not in the middle. So how do you orient them to midline a little bit more? You can have them walk to a target at the back of their chair, using lines on the ground, different ways to get them to move. There's also eye movement training. So this study actually looked at, especially PSP, if you have clients with, the Parkinson's plus syndromes, you can really want to get their eyes moving. But if this therapist or this study hid tennis balls all in the room, and they had to stand there and look around for the tennis balls and see how fast they can find the tennis balls while they were turning and moving their head and looking for balance. So there's ways to make it more fun to get their visual system moving a little bit more. So I'd like everyone to stand up if you want. You can challenge your balance to stand on one foot or one foot in front of the other. And what happens, so people with Parkinson's are also more visually dependent. They use their vision for balance more because their somatosensory system is decreased and their vestibular system is. So if you test someone and you see that the minute their eyes move, now they're swaying and they're off balance, you know that they're using their eyes too much, that they have to integrate it. So see it for yourself. How much do you use your eyes? I was a dancer, so I use my eyes a lot. So stand on one foot and see, does your balance change? First with your eyes straight ahead. If you're a yoga, some yoga instructors tell you to stare at point. That's the first phase of a balance exercise, but then we have to progress. If your eyes jump around the room, and if we did, say, 10 seconds, how many rectangles can you find in your room? Only moving your eyes. All right, if you're standing on one foot, does that change your balance as your eyes move? Now you can move your eyes in your head. How does that change? Right, so maybe your balance doesn't change eyes open. What happens when your eyes are closed? How does that change your balance? So I think it's important to kind of see how that would make a difference. Since I have everyone up, we'll do one more. And I was thinking a little bit of it while I was watching the visual flow of, somebody asked about a vestibular client working with the virtual reality part. So now let's do, have a little bit of optical flow and do a VR cancellation. So I'm gonna do it sitting down for a minute so you can see my upper body. So I'm looking at my thumb, and I love this exercise for people with Parkinson's because I'm working on trunk rotation, right? And I'm gonna tell them to go to 6 o'clock. I'm looking at you guys right now, but I want you to look at your thumb as you turn, and then you're gonna come back, all right? So if I was standing with one foot in front of the other, I would be turning and coming back, and then turning and coming back. I just challenged everyone right away, and I don't know the audience, so that was my mistake. You could start at 2 o'clock, or you could start at 3 o'clock. The faster and the further I move, the more difficult. I do not know, because I can't see anybody in this lecture. This is the hardest part about virtual. I don't know what your backgrounds look like. If you had a plain background, so I have a plain wall on this side, I can focus on my thumb because the visual flow is not busy right now. Versus if I go this way, I have windows that are panes. I have a lot more visual distraction that's going to change. So pay attention when you're doing a balance exercise. What is the room that they're in? If you have a visual flow and this bothers somebody, think about walking in an airport. I tell clients, if you can walk the same with somebody, right? If I'm walking at the airport and I have somebody next to me, that person's walking the same versus somebody walking the opposite direction might be really hard for someone. So I might have their spouse be that like in between. So there's ways to kind of look if that visual flow is going to change somebody's movement pattern. So not sure if everyone had different balance parts. I'm going to keep going and do all the questions at the end because for some reason when I try to pull it up, it's not letting me. Oh, here we go. I can look a little bit. Okay, we'll keep going. All right, so now let's talk about your somatosensory system. This system I think is just fascinating. And when we were talking about the children's book that I wrote, I train a lot of my and talk about animals even with my clients, I think it's more fun and relatable. So a fun fact for everyone, because like I said, it's a Friday night, so I don't know if everyone's getting tired. If you stomp your feet really hard, right, what happens? What do you feel when you stop after you stomped? I wish everyone can add. You get that vibration, right? You feel that vibration sense. That's one of our somatosensory inputs. Elephants have one of the most highly sensitive somatosensory system, which is really cool. They're able to stomp and feel the vibration miles away to warn another elephant if there's danger. So that's one of our senses, is that vibration senses are somatosensory. Just like it's our joint reference, is my elbow straight, is my elbow bent, I can feel it, right? This is really important for people with Parkinson's. It's why so many people say, I'm looking down at my feet because they don't know where their feet are. That's where I really developed my product on integrating that sensory input, right? How do we feel the ground? How do we know where we are in space? So for people with Parkinson's, they have less accurate sense in detecting axial rotation direction, and it takes them longer to figure out how much they're moving. Left-sided had even more deficits in their thresholds than right-sided. And visual verticality is really important. So we do all these like exercises here, right? But if they don't know where the middle is, they're going to be back here. That's more sensory deficit than strength. So knowing to train both, I think, is really important. And if you just did all this strengthening, all this postural work, you stretched the pecs, got everything straight, and now they're looking at their feet again, now they're flexed. So you have to integrate everything and look at the big picture, I think, to really get that optimal and to get some carryover. So some ways that you can do somatosensory. So if you want to stand up again, and I'll stand up, like I'm a very kinesthetic person, if you haven't noticed yet, to train. So you can stand, and limits of stability, right, is at our ankles, how we move at our ankles. So I want you to close your eyes if you feel comfortable and feel all your weight onto your toes, all your weight into your heels. I'm putting my hands on my hips because I'm trying to keep my hips straight. This would be moving at my hips. That's a hip strategy, right? We're trying to move at the ankles. I have some clients who tell me they feel like they're on their toes. Some feel like they're on their heels, right? Can you feel where your middle is? All right, can you go now left and right? Can you feel where your middle is? So some people with Parkinson's, if they have a dystonia or a PISA syndrome, they might be here. So all my weight's on my right and I'm here. So I might have them put their hands on their rib cage. Can you straighten that out? Can you, right? So getting that awareness of where they are, because a lot of them don't know. I use laser lights a lot on the chest. So that's the same thing. You have a visual feedback of where you are. And then I have them close their eyes and then maybe move and then feel that again. So there's different ways. This is one of the pads. So I had a client this morning who she kept feeling like she was swaying, right? And kept going forward. So here has a clicker at the heel. So she can hear if she was going forward. There's one right here at the toe and one here. So if you look at your tripod, this is where your weight distribution should be, right? So it's a nice way for clients to be able to click and hear when they go forward and back, and also get a little bit of the vibration underneath their feet. So when they close their eyes, they can kind of know when they're not doing it correctly. So that's one way to increase the somatosensory if you're looking at ankle strategy. I said two different postures. So for Parkinson's, if you're flexed forward, this is the only time I let them do a little bit of error augmentation. So if you're flexed forward, my weight's on my toes, my limits, I'm already going, I can't go any more further forward. So what's going to happen is I have to step. And that's my last line of defense, right? So if you have that better posture, play around on how much you can move at your ankles with tall posture versus here. That's why you're going to feel like you're falling forward already. So really important to be able to, for them to feel the difference and why they're working on posture. Bean bags, you'll see I use a lot on bean bags. Some people with Parkinson's will also tell you they feel lightheaded or that heaviness feeling, and there could be other things for dizziness or that lightheaded from orthostatic, but it could be a somatosensory deficit. So I increase a lot of references through their joints, approximation. I use bean bags, I use TheraBands, and different things to get that. So we're going to do another kind of combined vestibular and somatosensory exercise in a minute. So the vestibular system senses motion, am I moving, but also spatial orientation, where am I, for your head position. It's associated with dizziness, imbalance, gaze instability, and spatial disorientation. 46 to 80% of people with Parkinson's complained of dizziness. It didn't really tell me well enough, is that dizziness from orthostatic, which I have a feeling it could be, or is it also dizziness from some somatic sensation problems and the integration of the vestibular system? I think it's a combined, and it's our job to kind of figure out what is going on. This article was a great article looking at all the different symptoms. It just came out in 2024 in May, so I highly recommend to look if you want to go into more depth of understanding sleep disorders. Most patients with vestibular issues, actually, they're tired because it's actually, and can cause more cognitive, their brain's working harder. So I think it's important to kind of look at each of these different motor and non-motor signs. So they're not able to perceive some of the movement. Another part that I look at verticality is I look at head writing. So I'm gonna do a little training. And I loved, I'm going to talk a little bit about what I was just seeing in the last lecture. So I want everyone to stand up and think of they're playing that game, or I was just kayaking last weekend, right? And I want you to think of, tell me what you see for me. And I actually think of this in boxing too. If any of your clients are with Parkinson's or boxing. So first I'll do boxing, then I'll do kayaking. And I wish, this is the hard, I wish we can, if anybody wants to undo their, or tell me what they see, or let me know. So if I do this with a client, or I was watching like the weight shift, when I do this, is that, what do you want to see? Look at my head. What are you looking at? So I'm going to put the chat open so I could see. My question to improve balance is in relation to vertical gaze and horizontal. Okay, I'll talk about that right now too. So if you're doing this, or even boxing, is this what you want for your client? So I wish I can see a thumbs up. We want the head to be vertical, right? So if they have the range, remember biomechanics is important because they might be stiff in their neck and can't, but I want everyone to stand with one foot in front of the other to make it a little harder. If your balance is okay. If your balance is not okay, please stand near something. But if I go here, my head's pretty heavy, eventually I'm gonna fall over to that side, right? If I can keep my head vertical, I can right myself back to the middle. If I can keep my head vertical, this is a hip strategy. Or, right, if I'm boxing, and I spoke to a lot of professional boxers, they're never gonna go like this when they're, right? They're gonna keep their head always vertical. So look at your clients when they're doing that. That is a head righting response. That's our vestibular system working. So I love kayaking. If you pretend to be kayaking, now you're using a hip strategy while you're having them, I put a beanbag on their head and work on keeping their head reference. That would be a hip strategy left and right. If I'm doing a hip strategy forward in this direction, the same thing, my head goes this way, it's vertical, or my head goes here, right? This would be like those hip leans. So I have people stand on a 2x4, or I actually use my foot pads and have them kind of stand this way on the foot pads, or I'll put two on top of each other so their toes and their heel is off, and then they have to be working in the sagittal plane to improve their balance. So really important to try to train the vestibular system. So one person asked, and let me know if I don't answer it to what you're asking, in relation to vertical gaze and horizontal gaze. I don't see the question, how to improve balance. So if there is, so I'll answer what I think, but if not, please send me another message. So somebody with Parkinson's, vertical is, for the saccades, is actually decreased more than horizontal. And if you think about it, your gaze should be, excuse me, 2 steps ahead of you for where your steps are. So if they, and I talked to this neurooptometrist about this because I don't understand, most of my clients, they're like, I'm looking at the ground, that's why my head's here. And I'm like, why can't you be here and look down? And some of them can't, right? So practicing and first assessing, can they look down and look straight ahead, back and forth? So I do a lot of targets when they're walking or balance, and I use like a wall mat for even some of the things I use for my system, is that even if they're looking down at a foot pad, then they have to look straight ahead. So teaching their eyes to go up and down will help you. If they lose their balance with eye movements, right, they might lose every time I look up, I fall backwards. So that's something that you can kind of start training if it's vertical gaze. Can you train vertical gaze without their head moving? Or if they can't move their head, right, if their eyes are going up and down, is it something that they can't, so say their eyes, they can't do this, they have PSP and their eyes don't move, and then I will really up-train head motions, making sure that they can move their head up and down and not lose their balance, because they're gonna have to do that even more, because now they really have to do that to be able to look all around them. So does that answer your question, Marie? I'm not sure if you can give me a thumbs up, let me know. All right. Am I moving too fast? Let me know if I'm realizing I'm talking fast as we're going. Let's see. So inclines, what does everyone do when somebody's on an incline? What are you looking at if they're losing their balance, and every time they're on like a tilt board, they lose their balance backwards, or they say, hey, every time I go down a hill, I feel like I'm running. What are you looking at? So I want you to think about it for a minute, right? So one thing is, if they're head and body references the angle. If my angle's here, I'm gonna feel like I'm falling forward, right? Because my body is following the surface, following the angle of the ground. That I call somebody who is somatosensory dependent. They reference the ground to tell them where they are. So that cue might say, I want you to keep your head, and even more than your head, your trunk vertical. If your trunk is vertical going down the hill, because you still have to look maybe down the hill, but if you can keep your trunk vertical and your feet, then you're going to have better balance, and that's going to be referencing your vestibular system. So doing lots of inclines. I love putting somebody's feet up, stretching their calves while they're doing maybe some rows, while they're actually closing their eyes and working their vestibular system. So you can really implement and slowly put layers on there once the patient's ready. So sensory organization, switching from one surface to the other. You saw that image before. So people with Parkinson's actually, in general for the research, are able to do it if they have time. So if I was on the ground and I had two different surfaces, so I was on a hard surface, and then I switched to here and I said, okay, I have some time to think, I'm on a new surface, they actually do okay. When they have to move fast from one surface to another, that is when they start losing their balance more. So you have to cue both the temporal and the spatial part of their movement. So you might have to then tell them to take a quick step as they move versus, and train that, because when they do a quick step, you don't want them to lose their balance. So in a safe environment, make sure that you're not just letting them take their time to go on and say, hey, they did great, they're fine. Work at different speeds and see what happens with their balance. When they change suddenly, that's when sometimes you'll start seeing some more sensitive changes. So I've been kind of going over interventions as I've been going over the, so we're gonna kind of go over a few more interventions, but I've been kind of doing that as we go. So we're gonna just do this kind of quick so that I have at least 5 minutes for some questions. So for Parkinson's and for any older adult, we want to promote this active lifestyle and really long-term engagement. Okay, so I think the looking at all balance training's one, but you know what? If somebody's fatiguing and doesn't have strength, they don't have good balance. You have to look at the whole picture, right? Task-specific training, especially if you're trying to get the quality of life, and then just to be able to get it, depending on the level, super important. But also maybe somebody wants to do a hard hike, you know, or 14 or something. You want to make sure that you're training to that specific goal. So really enhancing their knowledge of the benefits of exercise. I think this is really important to increase motivation. I talk about a lot of the studies, how it changes your brain, not just your, you know, muscles and all of that, looking at heart rate max and things like that, but really trying to get them to adopt new strategies. So I look at it, there's tons of different ways to exercise. It's our job to find out what somebody wants to be able to do to kind of find that right to keep them on track. So if it's virtual reality, is it an exercise class that they meet with the people, is I do an intergenerational program. I think we just, each person's individual and what might work for them. So I'm gonna go for neuroplasticity, right? We talked about, and the last lecture talked about it a little bit, of being, you know, looking at the saliency, the timing, the intensity, all of this is important. I'm not gonna go into that much, but really knowing that we have to see changes, right? We need this high dose. We need at least 3 times a week for balance training. We need this to be task specific. Lots of training protocols are just looking at this multifactorial part, not just one part. Just like you look at the rate of perceived excursion, there is a rate of perceived stability. That is just as important to look at. So if somebody's mildly unbalanced, are they, so I print this out also for my clients and ask them how hard is the exercise or how steady do they feel, because you want that also to be similar to if you were doing an aerobic exercise. So again, specific training, right? I hate when people just tell me, and I, you know, when I was a CI more with students and they said they're doing balance training, that was my biggest pet peeve. You can't just say you're doing balance training. You're doing balance training for what? To improve limits of stability, to work on equilibrium strategies, to work on APAs. We'd even go into like anticipatory, you know, motion. So what are you working on? And that will get you better results versus just general balance programs. So I went into a little bit about feedback modalities. That's something that I do a lot of research and studies on. When are you using visual feedback versus auditory feedback versus tactile feedback? So vision is going to really help you with that spatial information, the size of your movements, the range of motion, where auditory is going to help you more with the rhythm, so the speed of your motion, the symmetry of sound, if there is the timing of your motions, versus touch is going to be a little bit of a combination of both. So I'm going to just show one video, and this is kind of just showing this lady. I was trying to get her to get more hip extension, and you could see I was using visual feedback for her to get an erect trunk, and then I was trying to get her to get more hip extension because she can't feel or see behind her, so then she had to hit the clicker behind her to get the hip extension. So kind of to see what I was talking about.
So get that laser to stay up when you reach back, but you're doing a good weight shift now. That was it. Get that back clicker. Good.
So you could see that she was having a hard time isolating trunk extension with hip extension. So that's something that we're working on in that video. I also use the doorway a lot for vertical reference. So for having people to stretch in the doorway to know where they are in space. So here I was showing a stretch, and you can see the same client in a moment. So here I'm working on that terminal stance position, trying to get that weight shift forward, to learning how to initiate at the hips. And then this is that same lady.
When you lift
now
that
that she
back
has,
heel, your hip and your head should be in line with the door frame. Yeah, that's it. Fast as you can. Go. Put.
so that last lady, she really flexes forward a lot when she walks. So right there, I wanted, let's see if I can get, I really wanted to get this tall upright posture, and for her to feel that, to use the visual feedback from the doorway, and using sound to get that rhythm to go forward. So I'm gonna, this was just another video that this lady had Parkinson plus and had a really time getting in out of bed. So I actually gave her visual cues of where her feet go, where she has to scoot her butt, just to be able to help with that. But I'm gonna pause here and then see if there's any questions. And then if they're not, I can always share that video later and see. So I went through a lot of stuff. Actually, you know what, let me go real quick back to my presentation. I'll put this so you guys have my contact information, I realized. Let me just pull this real quick to the next one. So here is my contact information. Here's my website. I took a little break from podcast, and I just interviewed yesterday somebody on the pelvic floor and the feet and the connection between that. Dr. Gail Wetzler is going to be my next guest. So if you want to listen to podcasts, I have some blogs. And then if you're interested in any of the products, here's 10% off, or any of the courses that I teach that I go into a lot more depth. So I'll keep that up for a minute. But if there's questions, I'll go real quick to the chat. Let's see.
Thank you, Dr. Erica DeMarch.
No,
Yeah,
thank you.
guys, do you have any questions? I think I'm echoing. Let me see. Is it on your?
You know, I'm going to stop this, and then
Okay.
I used to be at less. Yeah.
Okay. Thank you. So let me see. There's a follow-through question in gaze with Meissner disease, or is it Meniere's disease? Then does it follow to attack more on vertical gaze destabilization rather than horizontal gaze? I think that's her question.
Are you talking about Meniere's disease? Is that what?
I think that's what she wants to say.
Yeah.
Because
So Meniere's disease, that would be a whole nother topic for me to go into depth, but would be more of their like, right, they feel like they're moving all the time, so you would try to increase their somatic sensation versus looking at their, like, I wouldn't be, most of them have a normal VOR and are able to stabilize their gaze. So I don't know if that answers your question, but there is actually, I can send, if you send me a message, I can send you there's a really good podcast from my mentor that she's done years ago that she talks really in depth about Meniere's disease. So if you have questions, be happy to send you more information, because that's a little bit more in depth than a minute left to answer.
So if the client or patient has visual and auditory impairment at the same time, what strategies would you suggest to do as an alternative?
So that's where, pick the 3 systems. So if they, and visual impairment patients teach you a lot, right, on how you can change so if they can't hear and see very well, then I use a lot of tactile, a lot of somatosensory. So putting, textures under their feet to hear, to feel, to be able to put bands and different tape or different things, a beanbag on their head, different things like that. So they get a better feeling of where they are.
Yeah, that's really good. The one that you have, Dr. Erica, the clicker. So our goal is just to improve more the click, right? And then that's how we practice the postural stability. So at least there's the ankle and hip strategy, something like that. So we wanted them to hear the clicks. That way we know that they're really moving their trunk, something like that.
Yeah, so I think there's all different ways to use it, right? So if you're trying to elicit an ankle strategy, right? So somebody, I was at a lymphedema conference teaching, and somebody had an overactive hip strategy, couldn't move their ankles, and they wouldn't move the clickers at all because they're just moving the hips. That kind of shows you, no, I want you to move it, versus somebody who might have an overactive ankle strategy. You're going to tell them to stabilize all the clickers, keep it quiet during a certain exercise. So you're going to use the auditory feedback based on the task or what you're looking at. And then I train and teach different ways to do that. If you're doing like a stepping pattern, you want to hear click, click versus like a smudge click if you're having a flat foot. So there's different ways to use auditory feedback depending on the task that you're working on.
Thank you. All right, guys. Thank you so much, Dr. Erica DeMarch. We really appreciate this, another great innovation. And we always so excited to use this technology. So as a token, we would like to thank you and offer you this certificate as well for this great presentation, and also for sharing your knowledge and expertise here in the Geriatric Rehab Summit 2024 5th annual event. Thank you so much, Dr. Erica DeMarch.
Thank you. Have a good weekend, everyone. Thanks.
Yes, please. And also put your information, how we can connect with you on the chat. Yes. Also your podcast, so we can follow you. All right, guys. So we have 25 minutes break for dinner for if you are in USA, based in US, and you have your breakfast if you are in globally in Philippines. So wherever you are right now. So let's do a 20-minute breaks and we'll see you again soon, okay? Yes, Dr. Erica, please write your podcast name here as well. Appreciate you. Great lecture. See you around 8:25, guys.